Good morning, everyone. I hope you can hear me. I'm Victoria Beadle. I'm the CEO of Alzheimer's Australia here in Queensland, and it's my pleasure this morning to officially open our session. Firstly, I'd like to acknowledge the traditional owners of the land on which we meet today and pay my respect to elders past and present. It's fantastic to see so many people here today, and we have over 100 registrants for today's session, and great to see so many people from the acute care sector as well as people living with a diagnosis of dementia. So a very warm welcome to you all. Before we start, I've got the job of telling you about the housekeeping. First of all, a little reminder about your mobile phones. If you could just double check they're on silent or safely switched off, that would be great. And in the event of an emergency, you will hear an evacuation tone. Please just calmly leave the room via the main door and follow the directions of our staff. You'll see our staff are all dressed in black with our teal lanyards. If you want to follow them, they'll make sure you get to the exits safely. The bathrooms, please exit. There's a map here if you have to have a little look at the layout of this huge building, but to give you an idea of where the toilets are there, they're easily located just the other side of the escalators. If you need any help, do catch one of the staff team to help you. Today we do have a quiet space for anyone to access. It is just highlighted here near the escalators, and we do have our trained team of support workers there. If you do need a bit of space, a bit of time out during today's lecture, you're very welcome to access that quiet space. You all should have a green bag with a beautiful owl on. Inside that you should have some information about today's lecture and some take-home documents. Please feel free to take them away today. There is a feedback form on your chair. These events, we really do try to tailor them to make sure that you get the maximum value from the sessions, and your feedback is absolutely imperative for us to make sure our next sessions meet your needs. So we'd really be grateful to hear your feedback on today's session so that we can continuously improve the lectures and information series that we put out to everybody. So if you could fill it in and hand it back, there's a feedback box at the registration desk today. And also just to remind people that there are CNE points available for today's session. To receive your certificate, please hand in your feedback form to staff members at the Rego desk, and they will be delighted to give you your points, which I'm sure a number of you will be glad to take. So we've got an impressive lineup of speakers today, all of whom are very passionate about improvements that we'd like to see in the acute care system for people living with a diagnosis of dementia. I'd like to say a very big thank you to each and every one of them for taking time out of their very busy schedules. They all have very important jobs in their respective fields, and it's great for them to come here today and share their experience, their research and insights into the subject of improving the care of people with dementia in particularly acute hospitals. Improving care outcomes for people with dementia in the acute care setting is just one part of Alzheimer's Australia's goal of making Australia a dementia-friendly nation. Alongside lobbying the government to implement the promised $39.2 million over 5 years to improve hospital care for people with dementia, I would ask you all to help us to advance this campaign by using what you learn today and taking it back to your workplace or to others, to share with others, to improve the outcomes of people with a diagnosis of dementia. Alzheimer's Australia is passionate about ensuring that people with dementia have a voice and are included in our events and in all of the work that we do. Today I have the pleasure of introducing Christine Bryden to the stage. Christine was diagnosed with dementia in 1995 at the age of 46. She was a single mother with 3 girls and had to retire from an extremely senior position in the Prime Minister's office in Canberra. In 1999, Christine married Paul, who's here today with us. Now aged 62, she says she's survived and thrived, that's your words, Christine, not mine, with dementia for 16 years. Slowly declining but adjusting along the way, and my goodness, advocating for the rights and interests of people with dementia, both here in Australia and internationally. A decade ago, Christine addressed the Alzheimer's Australia National Conference in Canberra, Since then, she's been a passionate advocate. She was the first person with dementia to be elected to the board of Alzheimer's Disease International, the world's peak body for people with dementia. Christine's written 2 books, Who Will I Be When I Die, which many of you may have already read, and Dancing with Dementia. Both have been translated into a multitude of languages and are read across the world. We've got them here today as well. If you haven't read it and you want to buy it, Christine's books are available for sale. Christine, you're a very special lady with so many talents. I very much ask you to welcome Christine to the stage along with me.
Well, that was some introduction. Oh. For those that were trying to work out the maths, I'm now 65, and next May it'll be 20 years since my diagnosis, which is, you know, quite a long time. I really think it's great that Alzheimer's Australia raises awareness of important issues like acute care relating to dementia, and it's through these signature events occurring around Australia. And I'm sure that today will be thought-provoking and rewarding for all of you. But as you heard from Christine Bryden, and I've written those 2 books, but as a person diagnosed with dementia, I'm really grateful for the work of the experts like our various presenters today. They have dedicated their expertise towards improving our lives, and particularly drawing attention to the need to improve our hospital experience. Now, I want to try briefly to describe some of the issues that we might face as people with dementia and how hard it can be for our families if we're in acute care. Now, I know you're all keen to listen to Brian Draper, and so am I. So I'm going to be brief, just 4 overheads. But why should I speak at this event, which is focused on hearing from Dr. Draper and other experts on this issue of acute care of people with dementia? Well, I'm also an expert, but in the lived experience of dementia. I've been diagnosed by one of the world's foremost specialists with frontotemporal dementia. It's Professor John Hodges. My words are disappearing. My behaviour is no longer calm, cool and collected, and my memory is erratic. There's no way I could manage my former position as Science and Technology Advisor to the Prime Minister. Indeed, it's hard to manage a simple day at home without the support and encouragement of my enabler, my husband Paul, my staff of 1 instead of a staff of, I don't know, 30 odd in the Prime Minister's Department. Together with all of my friends with the many diseases that cause dementia, I want you to try to understand how hard it is to live in this unusual and very different land. Each day can bring new challenges and losses, and we do rely on our family and care workers who might come into our home, or we might go into respite care, to enable us to function to the best of our ability in this journey from diagnosis to death. We do know what it feels like each day to struggle to cope in your world while we're disappearing into ours. We desperately need you to focus on what we can still do and to help us to achieve all that we can. Now, our struggle is particularly hard when we go into hospital. I've been hospitalised a few times in recent years, each time staying in for longer than the normal person, and struggling to cope whenever Paul was not there. Just hold on. This is not the same as my one. Oh dear, we've got a wrong one. Okay, I'm going to have this one. I did have 2 other slides, so I'm going to talk to my 2 slides while you've got that there. I was rushed to emergency in the ambulance, and immediately doctors were trying to stabilise my condition. There was a rapid fire of questions. I needed Paul to answer them as I felt very muddled and in pain. And by the time I got to the ward, the nightmare became even more vivid. Paul had to leave, and there was no medication written up for my dementia, nor any extra help for me when Paul was not there. If Paul did not come in and put my Exelon patch on every day, each day I just get steadily more and more confused and increasingly distressed and unable to cope. The fact that I had a pre-existing diagnosis of dementia was not recorded anywhere, and there was no screening done. And I've looked at some of these screens that they would use for people over 65. I finally made it. And I don't think I do that well. So there was no extra support for the ward staff and no explanation in my notes as to why I might have appeared confused. How do we really know how many people with dementia are in our hospitals when we don't record it reliably? How likely is it that my primary reason for going into hospital will be my dementia? Surely a medical or an orthopaedic emergency are far more likely. It just all seems too hard to work out how to code for our pre-existing diagnosis, the one that we're actually being treated for long term. As Julius Sumner Miller said, why is this so? When we have coding and resultant extra care available for people with other conditions such as diabetes, who I think are meant to be probably a smaller percentage, but I'm not the expert. Now, I'm now the consumer representative on a working group of clinicians examining the coding system and the resultant data collected in Queensland and working towards suitable screening tools so that we can begin to have accurate data for the number of people in hospital with dementia in Queensland. At the moment, it's a very low figure. We know that's not the case. Most importantly, once we have that data, we can make the case for improved care for me and all my friends with dementia. But most importantly, also reduce the stress experienced by staff in trying to cope with our distress. At night, I heard others, more confused than me, calling out for their wife to take them home and being told to sit down and have a cup of tea. There was no way of keeping them still or keeping them secure. The night staff was stressed out, but so was the person, very confused as to where they are and why. Now, my husband Paul tried to get there first thing in the morning, 7 o'clock, whatever, it was really quite early. And if he couldn't come, my daughters did their best to come instead, so that I always would have someone with me, particularly when the doctors came, but usually they're there even earlier. On their rounds, asking questions like, did you have your test yesterday? How would I know? How am I meant to know? And as the nurse looks on the notes and says, well, it's actually she did. So that's a problem. Then there was a form to sign handed to me by some strange doctor-looking person. Later, the normal registrar asked Paul, has she signed the consent form for the procedure? Well, I had no idea. So they checked on the file. Yes, I had signed it already. Well, was that informed consent? I don't think it was. And then don't get me started on those exhausting daily complex neuropsychological tests that I had to do. A pencil and a piece of paper was put on my bedside table. Carefully looking at it, I realised it's a totally mystifying way of finding out what I might like to eat tomorrow. All the dots to fill in. And I just gave up. It was just too hard to work out what it all meant. I thought, well, the nurses will give me whatever's left on the trolley and I'm not that hungry anyway. There has to be a better way. So I'm really looking forward to all the presentations today to find out more about what we know and what can be done. Thank you, Alzheimer's Australia, for giving me a chance to give an insider's view of being in acute care. And thank you all for listening to me today.
Thank you so much, Christine. Thank you, Christine. As ever, your stories are inspirational and remind us why we're here. Certainly, Alzheimer's Australia is here to ensure that we improve the outcomes of people living with dementia, and I'm sure you all share in that. And it's great to get that understanding from a real expert, someone who's experienced the acute care system firsthand with a diagnosis of dementia, and I think that was a very fitting start to our session today. Thank you. I'd like to now introduce you to our keynote speaker for today, Dr. Brian Draper. Dr. Draper is generously conducting a range of seminars across Australia for Alzheimer's Australia to showcase the latest research findings from the Hospital Dementia Services Project, which examined the care of people with dementia in acute hospitals. Dr Draper is a conjoint professor in the School of Psychiatry at the University of New South Wales and Director, Academic, Department of Old Age Psychiatry at the Wales Hospital, Sydney, Australia. He's Deputy Director of the Primary Dementia CRC based at UNSW and an Honorary Senior Research Fellow at Neurosciences Research Australia. Dr Draper has a range of other positions and also has published over 200 scientific articles and book chapters on topics which include clinical aspects of dementia care, young onset dementia, acute hospitals and dementia in Aboriginal and Torres Strait Islander people, care of stress, depression and suicidal behaviour, as well as a book, Understanding Alzheimer's and Other Dementias, which will be on sale today. I would like to welcome Dr Draper to the lecture this morning and like to say a very warm thank you for travelling to see us today in Houston.
Thank you very much for that welcome. Be up here in Queensland. I had no idea it was State of Origin Day. Until I got to the hotel and there was maroon everywhere. But I fly to Canberra before the game, so I'll probably find out when I arrive what massacre happened, I guess. So I'm not confident that the Blues will win, so I think you guys will probably win. So this is an area that has become increasingly of interest internationally for 5 or 10 years. And I think it's fair to say that ever since, I've been working in the area of dementia care for about 30 years now, and I don't think there's been any time in that period that carers at some point in time have particularly complained about quality of care the person they look after has got in an acute hospital. It's always been somebody who says something. And in general, I guess most of us have said, well, okay, there are bad experiences and we know they happen, we see them happen. But surely that's not the rule, that's not what happens to most people. And I guess these anecdotes started to build up around the world, and some very powerful descriptions, just like we heard Christine give, of quite ordinary experiences, kept happening. And I suppose it's really in the last 5 or 10 years that internationally and nationally, that research has started to actually show just how big a problem this is. And having identified how big the problem is, we now are really confronted with what are the solutions to this. So today, what I'm going to do is spend a small bit of time at the top end of the talk outlining the problems, but spend most of the time looking at types of solutions that we can actually put into place right now. And I think that's the key, is that much of what can be done, we already have the knowledge, we already have the capacity to do, it's just that we're not doing it. So first of all, we'll go through aspects of problems. Mentioned all this. Okay, this is the biggest problem, identification. The fact is that we cannot tell you exactly how many people with dementia in any hospital at any given time. And there's a lot of reasons for that, and I won't go into all of those reasons today, but to a large extent it comes down to training and of staff, but there are other factors too. We get a sense of the difference between what it's likely to be and what we think and what is recognised by these 3 studies that I've got up on the slides. I think they're very illustrative because they are studies done in different ways using different areas of quality in their information. So the first study is from the UK, and in this study they looked at one hospital, and the researchers were there basically embedded in the looking at all the acute admissions to the hospital of age 70 years and over, and examined every one of them independently of the clinicians. Okay, so it's a separate examination. and essentially found that 42% of all of those people aged 70 years and over had dementia. But only half of those people had a diagnosis of dementia before they reached the hospital. So in other words, this identifies at the outset the first problem. A lot of people, it's not just the hospital's problem, a lot of people reach the hospital without a dementia diagnosis to start with. And so staff are unaware, families may be unaware, that the person has dementia. So that creates the first problem. As one would expect, the rates are higher in older people. The second study is done here in Brisbane, and it involved 3 hospitals, 3 Brisbane hospitals. And the methodology was slightly different. Here, they retrospectively looked at case notes, but these case notes were actually done in a very high quality way, using standardized tools. So they, in other words, they captured more information reliably than the average case note put in a medical file. And again, looking at age of 70, you can see that the prevalence of dementia now drops down to 29% in medical patients and 15 to 16% in surgical patients. It's already a drop-off. Even when people are doing high-quality notes, there's a gap. Now, we don't know, of course, if in Queensland there's the same precise percentage of people with dementia in the hospitals, but we can say that it's probably not too dissimilar. Then comes the third study, the study I was involved in, which is the Hospital Dementia Services Project. Quite a different type of study, because our study looked at all of the public hospitals in New South Wales. So there's 222 hospitals. So our strength for our study is that we're looking at the whole of the hospital system in New South Wales. But we rely in our study upon the diagnoses made by the doctors in the hospital. So in other words, if the doctor didn't see it and it wasn't recorded, we don't know about it, because that's the nature of the research. So we looked at over 250,000 individuals who were admitted to hospital in a 12-month period, over 20,000 of whom were identified as having dementia. And we data linked all of their admissions, so if a person was in and out of hospital 3 or 4 times, we could follow that person through the system. And to maximise the number of admissions with dementia, in the sense that if the person received a diagnosis once, we counted that across all of their admissions. So that increased the percentage from around 9% to 12% we did. Because sometimes the person had the diagnosis recorded, sometimes it wasn't. It was a bit unreliable. So you can see what happens. Probably our numbers reflect the proportion of people who are recognised, and the top ones are probably closer to what's actually there. You can see the drop-off that's happening. Even with our numbers, and this is comparing in blue the hospital data, in reddy pink the general population proportions, you can see that even without lower numbers than it's likely to be, there are a higher proportion of people with dementia in hospitals than in the community right across the age range. And indeed, even with our numbers, because we've got data linkage and we know that we're looking at individuals rather than episodes of care, we worked it out that at least 1 in 4 people in New South Wales in that year who had likely to have had dementia was admitted to hospital. So this is the second important, I think, piece of information. People with dementia are in and out of hospital a lot. It's not, an occasional thing. They're in and out of hospital a lot. And that, so in other words, whatever we do, it's likely to be that there are going to be people in hospital with dementia. Why are they there? Well, very rarely are they there for anything to do with the dementia. And our data said it was about 6% of all of those people with dementia admissions were to do with the dementia. And that was probably being generous in saying that 6%. Most people are there for the acute medical problems that everybody else is in hospital for. Infections, strokes, heart attacks, having falls, fracturing hips, all of these type of problems. So this is, in a sense, identifies issue number 3. The hospitals are not there to treat dementia. The hospitals are there to treat these other problems. and hospital administrators and clinicians haven't really got their head around the comorbidities of acute care, whether it be dementia or, in my other hats that I wear in mental health, psychiatric problems, people with depression or other psychiatric illnesses, or people with intellectual disability have similar. All of these groups of people with chronic problems that affect their day-to-day living, when they get sick, they come into problems in dealing with acute care. There's nothing much we're going to say about dementia that doesn't relate to all of those groups in their own different ways. But one of the things that's really important to understand, we already implied it a bit earlier by talking about how often people with dementia go to hospital, that having dementia increases your risk of having all of these problems in hospital. So people with dementia need admission to hospital for these common medical problems more likely than a person without dementia. Particularly things like fractured femurs. People with dementia fracture their femur much more higher rates than people without dementia, and have head injuries. If you have a urinary infection, for example, you're 2.5 times more likely to need admission to hospital than if you've got dementia than if you don't. So the same, perhaps with a urinary tract infection, if you don't have dementia, you probably can be treated at home, much more likely. But in people with person with dementia, it's more likely to get more severely ill and require hospital admission. All of those lists of conditions I've got there that are written in blue tend to happen as you get older. That is, the risks of these things increase as with age. The bottom two, alcohol and epilepsy, it's the other way. They increase as a person gets younger. Now, when I've got here alcohol disorder, I'm not talking necessarily about alcohol-related dementia. I'm just talking about people who have an alcohol problem. Fact is that if you drink too much alcohol and you have dementia of any cause, it really increases your risk of ending up in hospital. Doesn't matter what the cause is. If it's Alzheimer's, vascular, name your diagnosis is irrelevant. If you drink too much, if you've got alcohol use disorder, you'll increase your chance of hospital admission by 500%. 5 times, 500%. This is quite a massive increase. Similarly, epilepsy, but the thing about that is, of course, that with epilepsy, some of the conditions that cause epilepsy are also much more commonly happen with younger people with dementia. As you know, epilepsy is increased in people with dementia, but particularly so in younger people. If you enter hospital and you have dementia, you're much more likely to get a procedure or some form of investigation. You're much, much more likely to have a complication of being there, such as being not well fed, having a fall, being given too many drugs like antipsychotic drugs. Pressure areas are more likely to happen, more likely to get a hospital-acquired infection, become deconditioned. And in fact, if a person with dementia gets any of those sort of complications, they've got a 20 times increased risk of dying in hospital. So these are deadly complications. Understandably going to require more hours of nursing care, and understandably going to become more confused. In fact, when we look at potentially preventable complications of hospitalisation, so these complications I've got listed here are based upon an international nursing coding of potential complications of hospitalisation that nursing care could actually make a difference in helping prevent. And so Cassia Bale, who's one of my colleagues who works with us in our project doing a PhD in this area. And so this is some from our data, and basically you can see that both in medical and surgical conditions, this is just the standard list. There are 1 or 2 others that aren't relevant to this presentation, but this basic standard list. Dementia is much more common in each of the areas. We look at the outcomes. We've already heard a bit about it. Basically, people with dementia in hospital twice as long. Now, these outcomes we've got here are based upon when we control for everything else. In other words, control for the type of disorder, where they were admitted, all that sort of stuff. So this is having control for all the things that might confound the result, age of people, all of that. They have double the length of stay. They have double the risk of dying in hospital. 7 times more likely to be placed into a residential facility instead of going home. And they've got a 30% increased risk of being readmitted to hospital within 3 months. So you can see on all the basic major parameters of quality of care that we have for hospital outcomes and hospital processes, people with dementia do worse. I'm not aware of one single parameter that they do better. One of the questions that's important to think through is that when we do some of this research and we look at things like how long a person's in hospital and we talk about double the length of stay, the question we should pose ourselves and think about is shorter length of stay a proxy way of measuring quality care? And there are pros and cons of this. For some reasons you could say yes, it could indicate that the person had an earlier treatment and diagnosis and treatment of their condition, and they got better quality care with less preventable complications. Maybe the hospital was a bit more efficient and had better interfaces with hospital community interactions. Maybe for all those sort of reasons, a shorter length of stay could well indicate better quality. But maybe not. Maybe you're only there for a short time. Maybe they kicked you out too soon before you were ready to be discharged. Or maybe just another way of masking that you go from one hospital to another quickly. And that may or may not be a good thing. Or it might be that they kick you out sooner because there's a nursing home bed available. But, it's not black and white. What about longer length of stay? Well, some situations, maybe where a longer length of stay is actually a good thing. For example, if you had a fractured hip, need a bit of extra rehab, staying extra few days, more than, say, the person without dementia, might be a good thing to ensure that you're mobilising properly and not going to have problems when you get home. Or it might be that you can be in hospital a few days to ensure that those community services that you need to prevent relapse and prevent problems happening are in place. Or in some situations that I've seen occasionally where people have been sent home awaiting a nursing home bed because the hospital doesn't want to keep the person in the hospital waiting for weeks for that to happen. So maybe that's not a good thing to do that, putting the person at risk to go home. So it's not a black and white answer. But I think in general, if we're looking at this kind of big system data, a shorter length of stay in general is probably better than a longer length of stay. In general. You can't be 100% black and white as the point I'm making. Yeah, there are always exceptions to that rule. It's stuck. Which one I press? It's not moving.
Yeah, if you just move that
one?
out of that.
Okay.
Yeah.
Okay, thank you. Right, so what can we do? So those are the problems. What can we do? So I'm going to go through a list of areas of solutions that we can consider, and that can be already done. I mean, the first one is very simple. Maybe we don't need to admit to hospital everybody who's acutely sick with dementia. Maybe we can actually provide better quality and safer care outside of the hospital, provided we have in place certain supports and systems. I mean, it's not just say, oh, you've got dementia, you're not going to be admitted. Not like that. It's about looking at alternative ways of doing business, if you like. So, for example, a lot of people with end-stage dementia and residential aged care are transferred to hospital when they get acutely sick. And the question can be raised, is that really necessary? Is that really good quality care? And in fact, we know that with good advanced care planning, when the wishes, person with dementia, family, involving carers, the GPs, nursing staff, are put into place, we can actually identify those people who don't really want to be transferred to hospital as soon as they get acutely sick. They're more inclined to want to be treated in the nursing home. They don't necessarily want to be resuscitated if they have a cardiac or coronary arrest. They don't necessarily want to be given intravenous antibiotics. Some may choose to have oral antibiotics, some may choose not to have antibiotics. That's their own personal choice. But we know that when systems are put in place that try to deal with that issue, it does lead to greater satisfaction in carers and the like. And it does reduce the number of hospital admissions for people at the end of life who end up, a lot of the cases, dying in hospital after a few days, when really they were dying and well have been treated in the facility. And why do facilities do this? Very simply, because they have no directive not to. A facility who has one of their residents have an acute medical deterioration without any other direction, they may not be able to get a GP in the middle of the night to help them, are duty bound to see that the person gets the best quality care. If they don't have any other directive to do otherwise, they could be understandably criticised for not doing anything. So it's a no-win situation. So advanced care planning is about taking that to try to deal with that. And of course, very few people have advanced care plans. It's something, there's a lot of movement around, as you know, to increase that, but not many. So that's one thing. The second thing we can do is reach out to the person where they live, whether it's in a facility or in their own home, and provide a good quality acute medical care with nursing and allied health support to treat those sort of conditions that are treatable at home, provided the extra support is needed. So sometimes a person might have a urinary infection, like we talked about before, and they might need a couple of days of intravenous antibiotics, but beyond that, they'll be fine. And a bit of nursing, a bit of support. Well, that could be provided in a residential facility quite easily. But they might need a bit of extra support, medical staff going out, nursing staff supporting the nursing staff in the facility to do that. And indeed, there have been numerous trials of this type of approach around Australia and other places, and it works. The quality of care is reported to be better. The complications are less, much less confusion. Very few people get delirious compared to when they transfer to hospital. And their response is very good. So it's no worse than being in hospital. They get better with their infections. Obviously, there are certain conditions you couldn't treat that way. You've fallen over and broken your hip, you can't have a hip replacement in a nursing home and stay there. Obviously, there are cases that have to go to hospital. We're not saying that we avoid it. But there are a lot of cases that don't need to go to hospital. At the other end of the journey, the person is in hospital, the person can be discharged home sooner if you've got outreach to support the recuperation period in where the person lives. In other words, the length of stay can be reduced, get them out of the hospital much quicker and back into their normal environment much quicker. All of this can be done. It needs investment, of course, and investment into those kind of services. When we did our research, which was a few years ago, 3 or 4 years ago now, we only found 40% of hospitals who even had aged care services in New South Wales had that type of service. And if they did have an aged care service, only 16% of New South Wales hospitals had that sort of service. So you can see there's a lot of room that could be made there in improving that. I have no idea what the numbers are in Queensland. One of the things that we found in our research was how important the front end of the hospital is. And this is the emergency department. I mean, making those decisions about assessing and admitting or discharging a person at the front end are really key to what happens in that entire journey. And we found there are a number of things that indicated that in our data. For example, people with dementia admitted on a weekend were much more likely to be discharged very quickly than people without dementia who actually tended to spend a long time in hospital. What we were seeing was that on weekends it was an admission likely because there didn't seem to be any other option other than to put the person in hospital, and as soon as the trained staff got there early in the week, they were able to get the person home. Whereas for people without dementia, these people were seriously unwell. They needed a lot of medical care, so they were quite different types of admissions. And perhaps if there was more expertise and services available on those weekends, some of those admissions could have been avoided. But the other big thing is having specialist aged care staff who have some dementia expertise in emergency department makes a big difference. And perhaps it's because they make the initial diagnosis earlier and get the right treatment going sooner. That's, I think, the key. And in New South Wales, we have this particular service funded by the New South Wales Department of Health, Aged Care Services and Emergency Asset, they're called. And they are an asset, they are really amazing. Because these staff, when we did our research, had been around for a few years, but only in a small sprinkling of project hospitals, and they were just starting to be built up. And now it's much more common. But basically, these are staff based in the emergency department who saw older people, usually aged 70 and over, something like that. And they did basic geriatric assessments and made sure they covered their cognition and delirium and all that sort of stuff, all their care needs and all that. And they knew all the services, they liaised with people, they sort of worked hard with a lot of people. One of the things we found was in our research, we visited 10% of the New South Wales hospitals and did site visits and spent a day and a half at the hospital. So we did a lot of qualitative research. And the sort of feedback we were getting was interesting from the emergency staff. Because a few staff were saying, well, you know, before we had these assets in our staff in our department, we really couldn't work out what the point was, why they were there, why do we need these staff? And now it's so important. They are the most critical part of people that we have, older people. And so, in a sense, it was illustrative of two things. One, it was illustrative that emergency care staff really don't get aged care. They try, but they don't. They think they do, but they don't. And it's only when it's put into their face, they see that there are different issues here and different ways of approaching, that they can learn quickly. Not that they can't learn quickly, but it's a different world. I mean, we're talking about the real clash of cultures here, acute and chronic care, really at its peak. But these sort of staff make a difference. And in our research, they certainly did. We found both quantitative and qualitative evidence of how important these people were. We talked at the beginning about the importance of identification, and really the key to identification is screening individuals as they come to hospital for their cognition. And many studies have shown that this is not done well, and many studies have shown how, as I already have done, how few people are picked up routinely without that being done. But of course, I think we need to pause for a second and just make a very important point here. In an acute hospital setting, the key is not dementia. The key is dementia. It is much more important in an acute care setting to identify a person with delirium than a person with dementia, if you have to prioritise. You don't want to, but if you did, that's the problem. Because if you have delirium and it's not recognised, it's not treated for whatever the cause is, you're likely to die. If you have dementia, you're not likely to die if it's not picked up for a few days. You might get pretty bad care, but you're not likely to die. Whereas people with delirium are. We had evidence in our data where we saw in big sort of numbers where certain individuals, certain hospitals are transferring people that they labelled as dementia to another hospital within a day or two of admission, and they died in the other hospital very quickly. And the other hospitals were step-down type of hospitals, so without any specialist care or anything like that. And our view is probably these are people that the hospital A had called dementia when actually they had delirium, and by the time they got to hospital B, where they were labelled with dementia, before they could do anything, the person passed away, type of scenario. And of course, we know that dementia is the biggest risk factor for getting delirium. So 70% of people in hospital with delirium have dementia. Whatever you do, you've got to focus on this group. So the key at the beginning of the story of the journey in the hospital is making sure that you've got in place very good quality processes to ensure the person, whether the person obviously has a cognitive impairment, is it due, the next step is it something that's acute that we need to treat very quickly, or is it something that may be more chronic, or is it both? And having protocols by itself isn't good enough. This is from the UK, where they looked at hospitals with protocols for these various common problems, including cognitive assessment. And you can see the drop-off between what the protocol said they should do and what actually was recorded in the notes. It's quite dramatic. So we know that just having a protocol is not good enough. I mean, in our study, 50 to 60% of hospitals said they had delirium and dementia policies and protocols. That's fine, it's a start. It doesn't mean that they did much of those. And, you know, Australia's been doing some wonderful work on delirium, for example. I mean, how many of you here work in acute care? Yeah. How many of you are aware that we had national delirium care pathways? Really, so few did. Oh, a bit more than the last audience I went to, where nobody had even heard of the things. The point I'm making really is that there are these very good quality pathways, but in fact, the implementation has been substandard, to say the least. You cannot criticise those pathways, they're wonderful. They're a great bit of work, leading international quality. But if nobody knows about them in acute care, what's the point? So we're doing a lot of work, but not many people know about it. Not many people who are at the coalface who really count know about it. Australia hospitals are accredited by the national standards. There are 10 national standards in Australia. I've got them listed there, things like governance, partnerships with consumers, infections, blood-borne things, and pressure injuries, and so forth. Now, there's not a single one of those that's specifically about dementia or delirium, cognition. Okay. There's a few there, however, that you can see that would have elements that are relevant to dementia. But not a single one of them has any sort of specific guidance about how you could make them relevant to dementia. Now, these are the standards by which hospitals are accredited. These are the standards by which the bosses of those hospitals have to get their jobs sort of reviewed and renewed. And if their hospital doesn't get accredited, bloke that goes to the bloke at the top type of thing, people just below. The point is that these are key standards of quality for hospitals. So it's important, of course, that we try to do something about that, because if we don't have dementia or delirium or combination covered in those standards, it's going to be very, very difficult to improve quality of care. So this is what led through some of that money we heard about earlier, this project from the Australian Commission on Safety and Quality in Healthcare, which is in the process of looking at how dementia delirium could be incorporated in those standards. It's done a big consultation in the last 6 to 12 months. And they developed a handbook which is currently in draft form, and it's going to look very good. It certainly focuses on both clinicians and consumers and carers. And the hope is that through this process, that when the national standards are reviewed next year, that an 11th standard will be incorporated that will be focusing pretty much on delirium, but will take in cognition as well. But also that all the existing standards, where there is room to include dementia-related aspects to the standard, to include it. And of course, pressure areas, medications, falls, all of these are key areas where you could easily do that. So we're hoping that that will happen. So that project is on the go and coming At one point I was hoping that Anne could join me on this tour, but the timing wasn't quite right for them, for the commission to do that. So that's the way it goes. But it would have been nice to have done it together, and then they could have talked about where it was going in a bit more detail. And of course, dementia care pathways, we talk about delirium pathways, and there's dementia care pathways. This is a project that I'm involved with, but run by the Melbourne Epicentre, University of Melbourne, and Melbourne Hospital, funded by the Victorian Department of Health. And this is, so care pathways, to those who are not aware, these are basically, they come out of nursing basically, but they're the essential steps in the care of patients with a specific clinical problem. So they basically set down the steps that you need to follow for that person. And by doing that in that way, you can reduce, as in some conditions, length of stay, hospital complications, etc. And the idea is that this sort of thing should be done for dementia in acute care. And just to give you a sense, this is a kind of an algorithm type of approach that would have. You can't read that, but you can imagine that at the top, in the top one of those top boxes describes a presentation to a hospital, and then tick the boxes say which way you go depending on how you answer various simple questions. And it's supposed to guide staff to do the right thing at the right time. So, one of the problems though in acute care, of course, is that people go to hospital for lots and lots of reasons. So the diabetes specialists have their screening instruments, the dementia specialists have theirs, the psychiatrists, like we have our depression screening instruments, and it goes on and on and on. And of course, if you're flooded with instruments, an older person has had multiple medical problems, then you're going to screen for everything. And so one of the issues is, well, how much time is there to do all this? Whether you're in general practice, or primary care, or acute care, both are challenged by the volume of work. So there are numerous validated tools for cognition. I've just mentioned a couple there, neither of which necessarily are best one to use in acute care. I've just mentioned ones that we know well in the dementia care. So this one view being expressed is that we need to be looking at integrated suites of tools, and this is where Len Gray from up here has been working on this for a while now. And he's been involved with the development of this called the Inter-I suite of tools, and there's one specifically for hospital acute care, there's others for emergency department and long-term care and so forth. And they cover all the basic geriatric conditions that older people tend to get. They look at falls, risk, nutrition, mood, cognition, and so forth. Pick up issues related to pressure area care and risk of confusion and so forth. So this is an integrated suite, and it can be done. One of the things that it does well is that, as you know, most screening tools have items that are covered in 4 or 5 tools. So you see, this obviously integrates those, so you minimise the number of questions that need to be asked. I'm not spruiking that specific tool other than to say, as a model, it may be a model that we have to think about. Maybe we've got to get simpler to get screening done. Maybe we've got to simplify the process of it to ensure that it happens. And maybe we have to ditch our favourite tool to get a compromised tool. Now, staff training, of course. I doubt if there's an Alzheimer's Australia presentation that ever doesn't include the need for more staff training. If there is, it's a bad presentation. Basically, we know that training is the issue with so much of what we need to do, whether we're talking about training in informal care or formal care. There never can be too much of it, and that's a reality of the work we're doing. But of course, in acute care, we're talking about staff who have had minimal training related to dementia care, and they feel often extremely lacking in confidence about what's best to do. There's often a lot of goodwill, but not necessarily the confidence to do it. So there have been a few programs, and I'll talk about a couple that have been looking at this, and I think they're good models. And it's interesting that each of them has it. Now, having said that, there are issues in some hospitals of hospital culture and that sort of gets the issue of stigma that we need to address. And the sense, you know, when in a busy hospital system, when everybody's under pressure, and if a person with dementia, or just the older person, as often is seen as a bed blocker or creating extra work for the staff, then there's a culture of blaming the victim type of thing that happens, and or demeaning type of people who act up or whatever. So nurse nightmares. These are quotes that we kind of had in some of our cycles. So, you know, it's still out there. Obviously, we've got to address that as a key issue. And I think this is the sort of style of way of addressing that. Although even Mark Yates from the Ballarat Hospital has been heavily involved in this sort of work for a decade or more now. He and I are having a chat a few weeks back at a seminar we ran in Sydney, and even he said, look, it's a challenge to deal with some of that cultural time. But even so, this is the sort of way I would recommend that we try to deal with it. And fundamentally, it's an all-of-hospital approach. We've got to recognise that every individual who works in a hospital needs to be trained. I don't mean just the nurses or the doctors or social workers. I'm talking about the cleaners, the reception staff, all the other sundry workers, maintenance workers. Everybody has to be trained. Because if we don't do that, then it will impact on the quality of care of people in the hospital. And in Mark's program, which focuses on awareness and communication, he's a very strong believer in having what he calls a visual cognitive impairment identifier. That is a symbol, which I'll show you shortly, which goes above the bed of a person with cognitive impairment, to alert staff that this person has some form of communication problem, some sort of memory problem. And of course, it is linked to screening everybody as they enter the hospital, or from the older people for cognitive impairment, identifying carers and making sure that that person is part of the journey all the way along, it's part of all the communications. So here we have a program, everybody's educated, screening people for cognitive impairment, you are involving the carers, and this kind of approach has been evaluated at Ballarat and plenty of other hospitals with positive feedback. That's the program identifier that goes up there. In New South Wales, a similar program, which is the only slight difference between this program and the one in Ballarat is that this has a more specific initial focus on delirium, which I think is important. But ultimately it's the same. It's talking about cognitive impairment, and it's talking about making a brain-friendly hospital. It's talking about education, screening, and in fact the principles are here. Early screening, delirium risk identification and prevention strategies very early in the piece. An assessment and management of the person with confusion, whatever the diagnosis is. And then communication processes to support person-centered care and education. So you can see the fundamentals are pretty similar. It doesn't include the visual cognitive identifier, so there's a bit of uncertainty. Some people think it's a good thing, some people are not so sure. But the general gist of it for the staff is much the same. One of the things we observed in hospital when we did our visits in places, particularly that didn't have aged care services, was how important having this multidisciplinary teamwork. And we saw excellent examples of very good teams working and excellent examples of very bad teams working. So the bad team, for example, would be a group of nurses on an acute ward at handover at 9 in the morning, or some sort of discussion at 9 in the morning, being told, well, the director of nursing has decided we've got 4 people in emergency, we've got to put them in bed, so we're going to discharge 4 people. Those are the 4 people we're discharging, work it out. And that was their discharge. That was the care planning and discharge planning as a multidisciplinary team. We didn't think that was the way it should be done. Then we saw the opposite, where we saw this most wonderful arrangements with people working together as teams and working through solutions without any specialist aged care really necessary. I mean, basically they worked out how to work as a team and how to liaise with families, community, and all that sort of stuff. So it can be done. People need to be encouraged to do that. In terms of working with carers, this is a wonderful, simple program from New South Wales Central Coast Top 5 program, in which, in essence, it's all about at the point of care, of admission, the carer, nominated person, is asked, well, tell us some things about the person that we're going to be looking after. What are some key things that we need to know to help this person? For example, when do they like to have their shower? Or, is there anything you can tell us? Oh, my husband, he really hates having a shower in the morning. We try to give him in the morning, he'll just get so angry with you. You've got to give it to him after dinner at night. So, do that. You avoid all the anger in the morning when the staff go around with their routine showers. You follow me. So that's the gist of it. Just what are the key? So they just get 4 or 5 things. They put it in these tips in to way to communicate or way to interact, some information about the person, accessible to all staff, and the evaluations have been very positive. It's a very simple device. There's nothing high-tech about this, but it works. Do specialist aged care staff make a difference? I mean, here I'm talking about aged care staff in acute hospitals, wards, and multidisciplinary teams and all that. And in our project, I'm not going to go through this slide in detail, just pointing out that we capture a lot of information in our research. And so we were able to put together all that information. In fact, the amount of information was so great it crashed the whole computer system of the Australian Institute of Health and Welfare over one night when we were doing some backup. So it's a large data set. The point is that with that information, integrated information, we were able to look at patterns of hospitalised types of care so that we can take everything into account. So when we take everything into account as much as we could really reasonably measure, yes, they do make a difference. So hospitals who have these specialist services, that have specialist wards, have shorter lengths of stay, they have reduced rates of discharge to nursing homes of people without dementia, but about the same for people with dementia. But they do tend to do better. And in fact, when research trials are done, where they just do randomised controlled trials of these types of care, that's what the randomised controlled trials have tended to show, that acute geriatric wards, etc., the full disciplinary team, multidisciplinary team, do much better than other types. And of course, what we're showing is that this is happening in the real world, not just in a randomised controlled trial. We always worry about randomised controlled trials. Right, it shows something, but does it actually happen when you get to the real world? It does. In the real world, that's what happens as well. And that's description of the sort of thing that these hospitals have, the whole range of services, including the emergency department specialty involved. And as you can see from this slide in New South Wales, for those of you who know New South Wales, NSW stands for Newcastle, Sydney and Wollongong. That's where all the services are. And that's what the slide shows. So there's a rural drop-off here that's really quite a problem. I have no idea what it's like in Queensland, but that's in New South Wales. And longer length of stay certainly may reflect poorer care, and these tended to, in our studies, tended to be smaller, medium-sized hospitals. They had geriatricians they were just visiting for the day, often in regional areas rather than in the centre of the urban areas. A lot of transfers and so forth. We can improve hospital design. I'm not going to spend too much time on this. We've got a presentation coming up directly after, but basically, hospitals are not designed for people with dementia or for older people. There's only one hospital in the world that's purpose-built for older people. Only one for acute older people. One in Canada. So we need to look at what can we do to improve that. We observe some good quality aspects of design, some areas where people had secure areas for people who were more agitated and confused. So obviously every person with dementia doesn't need to be in a secure area, but those who are very restless and confused may well prefer to be better managed in that. But also a more user-friendly environment. We went to one particular hospital, and as is all the case with most good environments for people with dementia, you couldn't tell that everybody in that room was confused, because the environment was so good and the staff knew what to do. But you know, there were plenty of examples of the opposite. And there was we found a lot of goodwill and people trying to do things. One interesting one was one rural hospital. They painted this precipice in front of the door so that it really was scary, so that people with dementia got scared and walked near it. And it kept them from walking out the door. Whether that's the best way to do it, I don't know, but it was better than and of course, discharge planning. I've already talked about that, mentioned that a little bit at the top, related to having outreach post-discharge to reduce length of stay. But of course, all of this communication that we've talked about already, all of this multidisciplinary teamwork we've talked about, a lot of that is about what are we going to do after discharge? And as most discharge planners will tell you, that should start at day one. You always think. See, I've got a slightly different view, I must admit. I've always been of the view, you start off by saying, well, why do we admit? Not why do we discharge? So first stage is deciding to make that decision to admit. But once you've made a decision to admit a person to hospital, you then ask yourself, well, how are we going to discharge this person? You know, they go hand in hand. But I think we do have our thinking a little bit wrong there, in that we don't start at that first step often enough about asking the question about, is admitting this person in their best interest or not? And that goes across the board for any medical condition, not just dementia related. But certainly, we looked at aspects of community care. So one of the key things about our hospital dementia services project was that we had lots of information about community services and residential aged care facilities, as well as the hospital. So we could look at the interfaces that were happening, and when we did our site visits, we were talking to the community staff as much as the hospital staff. And certainly it was very clear that where there were services available, it helped that. It made a difference. So hospitals can do a better job if there's better services. It's what we sense, but it's certainly what was shown. So we can't, the important message of that for me, that I want to hear, is that, okay, we must focus on hospitals. We can't do it in isolation of what else is happening. Hospitals are not isolated from the community. Hospitals are part of the community. It's just that they are a certain part of the community. And so too much in healthcare worldwide has got it wrong related to hospitals and community. It's hospital care or community care. It's not. It's integrated care. And indeed, we know from research that if you can integrate your care processes, and that's community into hospital, from hospital into community, into residential, and so forth, all of that as an integrated package, you do better. And so that really is the most important aspect of getting it right, is to make sure we don't continue these kind of silos of interventions which don't get right. So just to finish up, people with dementia are prevalent in acute hospitals, and it's not going to change. And they have terrible outcomes at the moment. We've got to change the way hospitals function to address this. But the point is that we actually know most of what we need to do right now. We don't need much more sophisticated research to tell us the sort of things we need to do. We need to evaluate doing some of those things, absolutely. But we don't need to do big sophisticated research. What we need to do is to put some of these things into place and do further system-related evaluations, having put it into place, what outcomes that occur. And I don't think much of what I've talked about as to what we can do is actually cost that much money, to be honest. I mean, it costs a bit, but not that much. We're not talking about big dollars, to be honest. So that's good, because I mean, at this current phase of the government cycle, no politician wants to hear that you want money. But they do want to hear if you can work out a way to save the money. And that's what we're currently working on at present, is in a costing exercise from our data, working out potential savings that could happen if we did it better. That's current work in progress. Anyway, thank you very much.
Thank you very much, Dr. Draper. We might have just a couple of minutes for a few questions. The research is really interesting, and while it's fresh in everyone's mind, I sort of like to just ask the questions if there are in the audience. Yes,
I was just wondering, in one of the earlier slides, talking about the screening tools when people come in, I think it's a great idea. But I've sort of noticed they get misused. People will get a dementia screening tool applied to them, get a low score, often they travel with it time. And then when they come back a few weeks later, that score is sort of filled up as being where they are now, and they might be. How do you deal with that situation?
It's actually, your question actually raises a very important point. Most of us who work in acute hospitals, I mean, that's where I work, we are very averse to accepting a dementia diagnosis made in hospital. It should set up a process, because more likely than not, when the person was admitted to hospital, they had some level of confusion or delirium. We don't know what that number means. It just means that person at that point in time had some significant cognitive change that may be due to anything. What should happen, and what doesn't happen often enough, is that a process should be set up for that person to be reviewed a few months or two later to determine whether that cognitive change is something that's more likely due to dementia or not. Now, obviously, there will be people who admitted to hospital without a dementia diagnosis, but when you actually talk to the families and get some information from the GP, it's pretty clear this person's had dementia for quite a long time, just never been formally diagnosed. But the kind of cases you're talking about, where I think anyway, where it wasn't particularly known beforehand, they're impaired on a hospital admission, and then the number is then used for infinitum without it being reviewed. That's too common, and it is a problem. And so, yeah, there's a lot more embedded in what I guess I've only just sort of skimmed the surface. But that's a very important one. There are misdiagnoses of dementia. It's not just misdiagnosis. Misdiagnosis is just as a national problem.
Any more questions? Yes.
Hello, thank you very much, Dr. Draper. Just on the question of delirium and dementia, and this is a layperson's question. If a sufferer goes to hospital and does have delirium, and that sounds like a very serious condition, if that can't be easily identified by trained medical staff, how does the carer and the family recognise that the person has this condition to send them to hospital in the first place?
Yeah, it's a good question, but in fact, in some ways, the carer and family members are in a better place because you know the person so well and you know what they're like normally, and this isn't how my husband, son, whoever is normally like. So in some ways, that's this key information about communication with care is so important, because you can have a person, I just think back to my father-in-law 10 or 20 years ago. He had a coronary bypass and he was delirious afterwards, and and had a hemoglobin of about 6, very low, needed a blood transfusion. But he was very together enough to say, I don't want transfusion, no, and took the family and said, it's actually off the air, he's not speaking. And so they had to, it takes that kind of interface to happen. And so families are key in this in a lot of cases, and they can provide most meaningful information. So if you do see a person you're looking after or a family member whose mental state is clearly different, and there's a medical problem, and you know, it may be that that's what may be one of the possible explanations for what's happening. And you're going to see it before many health professionals.
Can I make a comment on that? I think that's a really important issue for carers and people with dementia to be aware of. There's certainly help sheets on the Alzheimer's Australia website which actually explain the symptoms of delirium versus dementia, and I think it's really important that people do make themselves aware of that and are able to pick up on signs and symptoms early so that they can access GP and acute care support as quickly as possible should the person in their care actually start with symptoms of dementia. So there is information out there, but it's a good question, how do we make sure that people know about that and are looking out for that, because obviously the impact of delirium can be very significant for the person with dementia.
Yeah, hi. I work with autonomous by caring, so I hear a lot from the carers' point of view. Our problem is a lot of time the carers will ring up, they're really stressed that they're caring for someone who has dementia. They try and get the doctor or a hospital to actually do anything to help them. It's practically impossible. They're just told to just go away, it's just part of the dementia. And quite often, as you said, if it's a family and the carer who knows the behaviour is different, we have the stress carer, we're referring them back to the doctors or to the hospitals, and they're just sending them back home. We just don't seem to be able to get any support for the carers or families when they identify there is a problem.
I guess one of the things that can happen, of course, that there can be, if the person is sent to hospital and it's assessed, examined, and found to have no medical problems, then I can understand them being sent home again, and that there may be the behavioural fluctuations related to the dementia rather than delirium or something like that. And you know, the other side is, are they assessed adequately when they are seen by the doctor, wherever that is, or nurses, wherever that is? And I don't know, if there's not been an adequate assessment, then that's the problem. In general, unless a person has a serious life-threatening medical problem, it's probably best not to be in a hospital, to be honest. You know, to be blunt. Hospitals are really there, are better for life-threatening or very complex sort of situations. That's how hospitals have gone. It's not like it was 30 years, 40 years ago, where hospitals had a somewhat different role in how we ran healthcare. And so the hospitals no longer really the centerpiece of chronic care as they might have been many years ago. So but what we haven't done is worked out how we do those interfaces better.
Thank you. We're out of time now, but I would like to say a very big thank you to Dr. Draper for his informative. Dr. Draper will be with us for most of the rest of the day, so you might be able to catch him at morning tea if you can get to ask your question. We've got a short break now, for about 10 minutes for tea outside the doors here, and we'll be back in our next session at about 10:50, so we'll call you shortly. Thank you very much. You're not allowed to go.
Yeah, I'm not sure about that myself. Yeah, I don't know. I have mixed views on it.
So I'll just get around kind of stand together here, but I have to get that in the background. Yeah, so these people want to They all look really tall.
So otherwise it's depressed.
So yeah, it'll be this one. If it does have a malfunction, it shouldn't do. Sometimes it just takes a while to kind of go across. So if you, yeah. So it's
Otherwise just clicking.
yeah.
And otherwise the kid is here.
Yeah, I'll get that for you. And my name is
Oh yeah, it's
yeah, no, that's good. So I've got your presentation. Yeah, let's have a look at it. I've got it here. Let's just check. It's all on mouse click. Yeah, so that's all on mouse click.
So that's
47 slides.
Sorry?
Is it 47?
Yeah, that's right. I just got a case study in case. And I couldn't actually show it as a slideshow on my computer at home. I just wanted to double check how the last slides come in. Okay, so if you just go back one or two. Is that for the last one?
Yeah, it is kind of on those bigger files freezing a little bit. So it is getting
So it's going to be a case of just almost pressing it before I want to change, and then it will take a moment.
Yeah, rather than have a pregnant pause.
But you're going to be there.
Yeah, I'll be there. So yeah.
Not that I'm paranoid.
No,
yes,
I totally understand. We want it to run really smoothly. So I think so it is just a matter of kind of hoping that the clicker, once we get that back, will work faster. But it is working. It's just not. I might grab it. We do have an AV guy, so I might see if he can help with the speed.
And I mean, I didn't compress the photos because I thought we wanted the best resolution.
Totally, yeah, that makes sense. But yeah, that's all right. So that's all there. It's all good.
Okay, great. So I'll
and we've got water just under there if you need it at any time as well. Just if you need anything, yeah.
And do you know the idea is there to have some questions, is it? Yeah. Do you know I can get a person to double check?
Yeah, we didn't have it built into the program, but I can check if we were just doing it for Brian, or if we, because
so I don't.
You didn't have
more
a
just how long
slide, did you?
No,
because I
it's only how long.
Yeah, we're going to be really.
And that's the same. I've got two final slides. Yeah. Because if I got through the first one quickly, I'll do the case study.
Yeah.
And if I haven't, so I've sort of got a plan B. Okay. Just because you never know.
actually hearing every hour.
Yeah. No, okay, so I more wanted to know that whether you were expecting me to questions.
No, but I will double check on that. Yeah.
Just because that would affect whether I finish up at 35 minutes to leave 10 minutes or whether I use my 45.
Yeah.
Okay, that's good.
Okay. Thank you.
How's the week going? No, it's not that it's assessed, but it's the
All right. So, that's for webcam. Where's who's up there? Let's unplug the clicker.
Yeah.
I think that's the most non-essential.
If something goes wrong with it, somebody can use the keyboard.
Yeah, which I'm pretty sure Brian was doing anyway, from what I could tell. That in there? That is the tiniest little USB I have ever seen.
I know, my professor gave it to me.
Yeah.
When we were presenting with the dementia part of the research fair last year. She found all these small.
Excellent.
It's great, yeah.
So, if you want to...
So basically, both. That's my first presentation there, and that's my second one.
Okay, well if you want to maybe even just put it onto the desktop, because you'll be here, so you can kind of... And then I'll just make sure we don't have the one that we have here with you. So I'll just close that. Just sort of say, Alright, so this one's your first one?
Yep.
Yes. Go. And then this one is your second one?
Yes, it's after lunch.
After lunch, right, okay.
Should be a bit different. Yeah, still a lot of use a few photos on it. Just take a little while.
Yeah, no, that's all right. I'll disconnect your USB for you. Actually, I suppose we can disconnect it. You're Store and Go, I think, are you?
Yep.
Sounds familiar. There we go. Yeah, it's still loading. Big one.
Yeah, it's.
There we go. Okay. All right, so I'll actually just close that one because it's not till after lunch.
Do that at lunch.
Yeah, and so this is yours.
Yeah.
All right, so we'll just go back to our holding page for now.
Thank you very much.
No problem. Bianca? Hey, so I just wanted to show you which one his is. He's doing a second one after, this is his one for now, so just when we're ready, pop that up, because he's just asked if someone can do it for him. And then I've just saved his one for after lunch on the desktop. Okay. For now.
So, and then can you put it on there, or how do I'll just get it.
Yeah, after lunch.
Yeah, after lunch.
Yeah.
All right, and so did he ask for us to put it on the screen, or take a picture?
He just said he could use the laptop. Oh, yeah, that it stopped working. Get a new one. Oh, okay, yeah.
They've got a look up here, kiddies.
Good.
Yep.
Yes, I don't know what's
Yep.
so while you're gone. Okay, it's faster with the clicker. Not really, actually. Yeah, I think it's because the pictures are higher resolution. Yeah. No.
That's how the clock res is running.
Yeah.
Anyway. Central reporting, see that? Yep, okay. Right.
Okay, everyone, thank you. It was either the food was really good or the conversations and the catch-up was good with everyone outside. I didn't get to try any of the morning tea. I've got some hidden somewhere away. I'll a little bit later on. Okay, thank you, everyone. My name is Jason DeBacker. I'm the Development and Innovation Manager at Alzheimer's Australia, and I can tell you about what that means at lunchtime if you're interested. Like I said, I didn't get to enjoy any morning tea, but I hope you did, and I hope you enjoyed the conversations with your colleagues and with other people in similar circumstances to yourself, if you're a carer or someone who has a diagnosis of dementia. We will be having a 30-minute lunch later on today after our next two sessions, and then afternoon tea after our last session for some further time for you to have conversations with others. Now, our next session is about the environment, and the environment is a vital factor in helping create dementia-friendly communities, both generally and in the acute care sector. So there's no one better to talk on this subject than Kirsty Bennett. Kirsty is an architect who's pursued her commitment to improving design of environments for people with dementia through architectural practice, writing, research and speaking engagements. Kirsty's architectural career has focused on designing small-scale residential environments for people, which are enabling and empowering. She has been responsible for the design, documentation and construction of many residential aged care facilities for people living with dementia across Australia. Over the years, Kirsty has spent a lot of time with people living with dementia, their families, staff and managers of residential aged care facilities, seeking to understand the issues that they face. Kirsty has presented at many conferences and visited settings in Australia, Europe, Japan and Canada, and has co-authored a number of and contributed to a number of publications on designing for people with dementia. Kirsty is currently the Manager of Environmental Design Education Services at New South Wales ACT Dementia Training Study Centre. I'm trying to keep acronyms short. I'll not use acronyms for you today, sorry, so I'm going to use the full words. And Kirsty, I think if I can just ask you to come up to the stage and begin your talk. I do think I was supposed to throw in a state of origin joke there, or have some sort of message about state of origin, but I missed it. I'll get them into the others later on.
Right.
Thank you.
Yes, and so just to be clear, I work for the New South Wales ACT Dementia Training Study Centre, which is based in Wollongong, but I'm a Victorian. So, state of origin, no offence. Not really. We'll just start at the beginning, that's usually a good thing. Thanks. Terrific. So I've been asked today to talk about how we can enhance the acute environment to enrich the care of a person with dementia. I think the best way to do that is to apply some key design principles. So what I'm going to do is introduce one of those principles in some detail to you today, but also talk about the methodology that we use at the New South Wales DTSC. My colleague is here, Tara Quirk. Do you want to stand up or wave? Some of you may know her. The Dementia Training Study Centre, while we're based in New South Wales, we offer a national design education service. Tara is our Queensland consultant. Richard Fleming is the director of the centre, and I'm sure many of you would have met him and heard him speak on different occasions. The first point I want to make is the environment matters. Now, you probably wouldn't be surprised, you heard that I'm an architect, so clearly I think the environment matters, or why did I choose to be an architect and work in practice? But it isn't just that architects think the environment matters. There's now growing recognition about the importance of the environment in the care of people. The environment is an important tool, whether you have dementia, whether you have cancer, whether you have a broken hip, whatever it is, the environment has a really important role to play. And we're seeing that importance now in some of the new acute settings that have been built. As I said, I'm a Victorian. These are a couple of images from the Royal Children's Hospital in Victoria. Some of you may have heard about this. The reason I'm showing you those is because it's a great illustration of the emphasis that was given to design. It's a very big, large project, and enormous care was taken to design a building that was going to be therapeutic and respond to the health and well-being of the children who will be there, as well as their families. You probably saw on the last slide the meerkats, which are a bit of a feature. The zoo is nearby. But this hospital also is designed around having a street, so there's lots of interaction, there's things for people to do, there's cafes, there's places where you would actually go and just have a coffee because you're looking for a coffee, not because you're in hospital. This is quite a change in thinking about how we design an acute setting. That when you think, where would I like to go to have a coffee, to go to a movie, to see the meerkats, then you're thinking, I'll go to an acute setting. The Royal, no, it's not the Royal Children's in Brisbane, the Children's Hospital in Brisbane also is being given a lot of attention from a design point of view, and it also is adopting a salutogenic approach. There was a conference here last year, a design conference, international conference, which was about salutogenic design. I'm not sure whether many of you would have heard of that term. I certainly hadn't, but was very interested to hear it and realised, well, that's actually what I've been interested in for the last 15 or 20 years. But within the healthcare setting, so in acute design, there's great talk about designing a salutogenic environment rather than a pathogenic environment. So salutogenic focuses on health, pathogenic focuses on illness. And they've identified 3 areas, comprehensibility, manageability and meaningfulness, that are really important in creating a salutogenic environment. Those things you will see as we start talking are very much important in designing for people with dementia. So the first couple of things I'm saying is the environment matters, we know it matters. We're seeing that in the way acute buildings are being designed, albeit for children, of course, the next question is, how come that's not transferring to the general design of acute settings? But at least something's happening, so that's good. We're seeing an emphasis on design and the recognition of the role that design can play in our health and wellbeing. There's been a paper published just recently which looked at quality of life in residential aged care, and it identified that the environment contributes 13% to the quality of life of the person in residential aged care. And just in case you think, oh, 13%, medication didn't rate as significant at all. So putting it in perspective, as far as what contributes to quality of life in residential aged care too, we're now starting to see the research, the data, that's backing up this idea of the importance of the environment and how an environment can be designed to be healthy. But often these are more the sort of environments that we will experience. Certainly in my work, these are more commonly the settings that I would see as I go to acute places. And I suppose some of the things that then cross my mind is, so why are buildings like this? You know, why are these the environments we're experiencing when we know about the positive aspects of an environment? Some of the reasons are that buildings are old. Buildings are tired. They're already there. It's great to be building new hospitals and designing new hospitals in this way, but look at where we're working. This is where we are. What can we do now? And that's something I'm going to be addressing. No money to make changes. I'm going to highlight to change a lot of those things. A bit as Brian's point was, we're not talking about money and we're not talking about a lot. And that's actually really good, because that means nothing's holding us back. We can actually make changes. We can make the environment work for us. So when we think we can do something about improving those environments, how are we going to go about it? As I said, I think the key is in applying some key design principles. We need to recognise that we are in conversation with our environment. I'm going to come back to these points and just spend a little bit of time on them. But to touch on that idea, we interact with the environment, we change the environment. And the more we're aware of that, the more we realise the ability we have to do something about the environments for the better. In doing something, we need to make a start. There won't be the perfect day, the perfect budget, the perfect site, the perfect boss, the perfect opportunity. So we actually need to make a start. We need to be persistent, and there are resources out there. So use those resources. Now, I mentioned key principles of design, and you can see that there are 10 principles there. They've been identified over a number of years. I would say to you, I believe that they're not just good principles of designing for people with dementia, they're good principles of design. All of us, for example, arrived here and thought, where do I go? How do I find my way? What's the next step? Oh, what's that noise? Common things that affect all of us. And that's a plus, because that means these can benefit every patient in an acute setting, and not just a person with dementia. They're evidence-based. There's a body of evidence that's been developed over the last probably 30 to 40 years. And from that, we're now able to say with confidence that a well-designed environment can reduce, as you can see, agitation, anxiety, the number of falls, restlessness. Stress associated with bathing. Think about how daunting it is to go into an ensuite when you might not be clear why you're there, what you're meant to be doing, and suddenly someone wants you to take your clothes off and make yourself even more vulnerable. It's not surprising that often people respond in a certain way. The environment is contributing to people's behaviour, and we need to recognise that. Because once we do, then we can do something about it. So knowing that a well-designed environment can address a number of things, that's an interesting order, what I want to do is just focus on one of those principles, because as I said, I'm going to highlight to you the methodology we use. When Richard and I do workshops, or Tara and I do workshops at places, we'd spend anywhere from 3 to 6 hours unpacking the principles. And so that's really important to recognise that they are complex. It's very easy with principles to have a little catchphrase and to think that's it. What I'm going to be highlighting to you today is the importance of unpacking a principle, the importance of understanding what it really can mean in this place for these people. You can see there's some of the key points that we would think about typically when we say it's important to create a familiar space for a person with dementia. And just at the outset, I'm highlighting, I recognise in an acute setting, it is very different from residential aged care. Residential aged care, people come for a time, and that actually is the focus often as to why someone's in residential aged care. Whereas, as Brian emphasised, in acute, people are in acute for all sorts of reasons, and they happen to have dementia. So, as we look at how we change the environment, that's where it's really important to recognise this is good design for everyone. And as we look to see how can we make the environment respond to a person's needs, that will be the same for all of us to a greater or lesser extent. So having said, these are the sorts of things we'd like to pay attention to create a familiar environment. What I'm planning to do now is to just show you some examples. So, what would you think if you're admitted to hospital and you walk in and you're shown to this room? Does this look like a room you sleep in or live in or use? How would you feel if you walked into that room? Would the environment be saying to you, welcome, we've been expecting you, we're ready for you, you're going to receive really great care here because you're important, so don't worry, you can relax. So that highlights a point, doesn't it, about the role the environment plays straight away in that first few seconds. And we need to make the most of that, because that then sets the tone that someone can walk into a room and feel welcome. This is another room in an acute setting. So as you look at that room, how is that going to make you feel? Now, I'm not saying that room is perfect for, I'm giving you wrong examples. I'm not for a second saying this is the perfect familiar room. What I'm saying to you is you see the difference between those two images when you walk into one room and this is your welcome, and you walk into that room. And you can start to see that they have used colour and finishings. So as you walk in and you think, is this where I should be? What should I be doing here? You're starting to get more answers when someone has taken some care and trouble with the environment. I want to show you those two pictures because the one on the left is from the AP Winelands, which is in northern South Australia. So that's an Indigenous multi-purpose facility, and they take people with acute conditions. And so imagine if you had left that home and that was where you slept, and then you were placed and asked to sleep here. It's going to have an impact, isn't it? So again, we can start to see why someone might react in a certain way. The reason in particular I'm juxtaposing those two images is because it's so easy to think we know what familiar is. Just as with person-centred care, there is a need to get to know the person and their stories and something about their background. So it is with the environment. And I understand that in acute, people could be coming in for anything from hours to days, but sometimes weeks or even months. But I'd suggest to you taking that time to get to know the person a bit, speaking to family, as Brian said, using whatever tools you have, and then using that to change the environment is going to help the person feel at ease. It's going to help them function. It's going to help them use the abilities they still have. If I'm feeling stressed, I'm not going to function well, and the environment has a key role to play in that. So how do we respond to different cultural backgrounds? How do we respond to our different lifestyle preferences? How do we respond to our different socioeconomic backgrounds? all of that has an impact on what is a familiar environment, where I feel at ease, where I feel at home. It isn't just about putting up pretty curtains and a nice bedspread. That is great and is certainly much better than doing nothing. But if you're able then to really unpack and think, what does this principle familiar mean for Kirsty at this point? And is there something I can do to help make the environment more familiar for her? Then I will know this is my ward, my bed, my place. I will have a greater sense, or maybe this is where I'm meant to be. I don't know why, but maybe this is where I'm meant to be. As part of a series of seminars we did last year through Australia on designing for people with dementia in acute settings, we spoke to some people with dementia who were part of the Consumer Dementia Research Network. And Christine is a member of that, Tara is a member of that as well. And it was really important to us to try at least to get that glimpse of their story, as we heard directly from Christine this morning. And this was what Steve had to say. Steve is someone who has younger onset dementia. He used to fix office equipment and then worked in aged care. And he's actually spent a lot of time in and out of hospital not to do with having dementia. He found it incredibly hard. He had a young family. And as he said there, everything was grey and inviting, uninviting. It didn't make him feel human. And he was alienated and separated from his family. If the environment had been familiar, he would have been able to function much better. But let's not just think about the room, because of course that's not where we spend all our time. What about as I leave my room? What am I going to see? Is this my view? So how will I find my way? How do I know where to go? How do I know what I might find if I get there? This is still a pretty uninviting environment, but look at that difference that bit of strategic colour makes. It's adding a warmth. So again, think what could help make this place more familiar, and in doing so help people find their way and have a sense of where they could go and what they might find if they go there. Now it's quite funny because I knew this was from Brisbane, and I walked in this morning and I thought, oh, I know exactly where this is from. So clearly these are examples that aren't from an acute setting. And I chose them because this is the big picture. How do we design so that places are recognisable, fixtures are recognisable, their function is recognisable? The one on the left is from here. So I'd suggest to you that when you walk in and you think, so, yeah, where are the taps? Where's the soap? Is this a basin? There's no invitation to wash your hands, is there? And that's what we need the environment to do. We need it to be familiar, so it issues an invitation. Do this. Come here. That's what an environment can offer. The one on the right, I'm not being parochial, the one on the right's from Victoria. It's from Melbourne, it's from the Arts Centre there. When you take someone with dementia to the Arts Centre to see a show, and you need to go to the toilet first, well, it actually can become a bit of an ordeal by the time you explain that this is the basin, and that is where you're meant to wash your hands. They are taps above, and all those mirrors aren't the room extended behind you. So you can see it's unfamiliar, it's not recognisable, and it's not helpful. In an acute setting, would you recognise that that door on the left leads you to the toilet? So as you find people walking around, perhaps there's a good reason they're walking around. They're trying to find the toilet. And there's a reason for the behaviour. The environment isn't helping. And it's simple. We could do something about that. And then when I get inside the toilet, can I see it? No. It's white on white on white. The most obvious thing to do would be contrast the toilet seat. That at least would be a start. That's a toilet paper holder on the left. Again, if you want someone to use the toilet paper, make it look like toilet paper. And if it doesn't, then understand why someone maybe hasn't used it. It wasn't they were being difficult. Some of those terms that Brian identified are the labels that are given to people. It's really important to see the environment is disabling someone. What about waiting? When you go to an acute place, often you need to wait. Does this encourage you to wait, to relax? Take your time. It's okay. They'll be here soon. No. So don't be surprised then when a person with dementia looks and thinks, well, I'm not meant to sit here for long. It doesn't look like a place to sit and relax. I better get going. Better do something. It's not comfortable. It's not inviting. Again, staff have done their best. There was no room to sit in this place. So they converted a storeroom and put a couple of chairs in. Great. That is a fantastic improvement. But it's still not going to be familiar, is it? So don't be surprised. We've done that. Good. But it's not enough. This sort of area is more likely to say to someone, sit down and relax, isn't it? Again, great intent to have seating outside, but it's not familiar, it's not recognisable. Familiar is about being recognisable, and in recognising it, that gives you the invitation of what you are to do. So here the chairs are, I think, they've got some positives, but what about the floor? I'm sure most of you would be thinking, oh my goodness, if you've had spent time with a person with dementia, you know that's daunting and could lead to a lot of stepping. Again, it's not necessary. It doesn't need to be like that. This isn't for people with dementia. No, this is in a kids area. But I might be going with my daughter to the kids' hospital. So why shouldn't I be able to go and be okay? And then my daughter, who may well be caring for me that day, she doesn't need the stress of me not being able to walk on the carpet and the child meant to be being in the waiting room waiting to be being seen. So I think too about a person with dementia goes everywhere in an acute setting. And all the different parts of an acute setting need to be designed to be many things, but I'm just saying at this stage, familiar. And again, what if that's where you're used to sitting? I'm not saying that's what we replicate, but recognise if that's what a familiar sitting place is, those others are going to evoke very strong reactions in you. What about the climate? I don't know if I mentioned before, Steve comes from the Glasshouse Mountains, and one of the things that had a big impact on him was when he went to hospital, he was stuck in air conditioning. And he said it wasn't good for him then, but it also wasn't good when he went home, back to natural cross-ventilation. So it had a detrimental effect on his health. Is the climate familiar? When we think of outdoor places, where are people coming from? What's a familiar setting for them? Doesn't mean it has to be perfect. Let's recognise we all come from different experiences of reality. This is a terraced type area. So is that familiar? Is it going to invite someone to do something? Is it going to make someone feel at ease? And think about what could we do to change that. There are planter boxes there. That's the sort of thing we could be looking at, that you could do really easily and simply to start making the environment more familiar and welcoming. This is at a transitional care place in Victoria. And when I walked there, it's pretty empty, but actually there's the bones of something that's like backyard. So it's actually quite familiar. Not everything has to be designed. You can also just be. That's where most of us live. Don't be afraid of that and don't think you've got a bad option if you have an average spot. They can do more, but there's a lot of potential. Whereas somewhere like this, again, is very designed. You can see the difference I'm making there between very designed and not designed. So both, if we're going to design, we need to design a familiar environment, but don't think you have to have this sort of environment. Apart from being an inpatient or going to visit, Leo, who's a Tasmanian person living with dementia, he went to the hospital to make a complaint actually about a doctor. So he went to have a meeting. And what was really hard was when he got there, he sort of was shown to a storeroom to make the complaint. Now it's hard enough to do that anyway without having dementia. And when we said, so what would have made a difference, Leo? He said, well, appropriate room, right size for the meeting, quiet, natural light, chance to talk around a table. He's not asking for a lot, is he? But recognise the impact that will have. If we have appropriately designed spaces that are familiar and recognisable for behaviour, it will empower people. So now we talk a lot about these principles when we do our consultancy, and I am very conscious of the time. And so I've just focused on one and given you an idea how we unpack a principle and really look at context and what does it mean in this situation. It isn't about creating a checklist. That is not the goal. It's understanding the principle and using it. There are some resources available that you can use to do that. And I'd encourage you to use the resources that are out there. The left one's the audit tool that Richard Fleming and Forbes and I developed some years ago now, and there's a new one in development. And the handbook, which goes with it, explaining the audit tool. And I know a number of people from DBMAS in Victoria and Queensland are familiar with this and are using it, which is great. But the purpose of these is to start a conversation. It isn't to get a score. That's not the idea with this audit tool. It is to start the conversation. These questions, see them as starting points, and then what else would we say about this principle? And see where that could lead you. I want to just touch on this because one of the things I said that was important if we want to enhance the environment for people with dementia is that we don't give up, that we be persistent, that we make a start. Knowledge translation, a paper that was done by Davis showed that it takes a long time for research to be transferred into knowledge, about 17 years. And then only 14% of it actually gets transferred. So as Brian said, we know a lot, but it's not being put into practice. I want to use that though to say to you, don't be disheartened. And that's why it's worth making a start. You might have a great idea. So think back to that sitting room I showed you with the chairs in the storeroom. Not particularly inviting. But who knows the battle that went on to actually get the stuff out of the storeroom and make it a sitting room. So that was a start. It's not the finish, it's the start. And we know that there are these 4 stages in translating knowledge. We need to first think, do you know about it? Are you aware? Do you agree with it? Is it a good idea? If it is, then, well, how am I going to make it happen? And then once you've made it happen, how are you going to keep it happening? That's how we change the environment. That you need to work together to get awareness, agreement, adoption and adherence. Don't expect it to happen all at once. Don't be disheartened when you do something and you go back the next day to find it's rearranged, it's changed, someone else appropriated that space. You need to hold on to these principles and say, we know they're evidence-based. We know there is good research behind these. These will make a difference to people's lives. So we're going to keep trying to implement them in whatever way we can. And we're going to widen the conversation. One of the things the Dementia Training Study Centre does is we offer a design education consultancy where we come out to acute settings and to residential aged care and talk about these key principles of design. And then we introduce the audit tool. We have a look at one part of the facility and start to talk about how we can change the environment to make it more friendly and welcoming for a person with dementia, more enabling for a person with dementia. But a key in that design education component, the conversation about the principles, is that we gather a group of people around the table from different parts of the hospital. We need the decision makers, we need the maintenance people, we need the orderlies, we need the registered nurses, because everyone needs to have that same conversation about principles and to appreciate and, I suppose, gain more insight into the importance of the environment in the care of the person with dementia. And as they do that, that means there's actually much more chance that the changes will continue. We're available to come and talk. As I said, Tara is the Queensland-based consultant, and I've got some flyers and I will leave them on the registration table so that if you'd like to be in touch with us about acute or, for that matter, residential aged care, please do. We also have an iPhone app that I know DB Mass are using, and oh, there we go. That's a start. Again, it's a good start, and it introduces you to the audit tool, and you can use that to go to environment and get some suggestions about areas you should be focusing on. But remember, it's actually about the principles. It isn't about answering questions in an audit tool. If we want to enhance the environment for a person with dementia, think about how we can apply these principles. I've only spoken about one, but I hope it gave you a taste of the variety of ways we can apply principles and possibilities that are there. Remember, you're in conversation with the environment, and so make a start. Have a go, and don't be afraid to call us or DBMS if you'd like to have more conversation. Thanks.
Thanks, Kirsty. I suppose the thing that I'm hearing throughout today with the first two sessions was that it's not going to cost us a lot. It just requires a little bit of different thinking and for us to be challenged and for us to learn from the experiences of each other to make these changes. So thank you, Kirsty. Our next speaker, a Queenslander, back in the Maroons, I hope, is maybe well known to many of you, is Frederick Graham. Frederick Graham is the clinical nurse consultant for dementia and delirium at Princess Alexandra Hospital in Brisbane. In his role, Fred has developed and implemented a special care unit for dementia and delirium, a behavioural observation tool incorporating dementia-specific pain assessment tools, an education package on dementia and delirium for all of the PA nurses, and established a nursing champions group to promote quality care for people with cognitive impairment. Fred is currently undertaking his PhD at the Queensland University of Technology, focusing on how acute care nurses make decisions about the care for people with dementia. So today, Fred is going to talk to us on a couple of topics, one before we move to lunch and one after. And Fred's first session is all about recognising the risk of dementia and delirium. Please come to us there, Fred.
Thank you. I have to confess I know nothing about rugby. Edmonds final Sunday morning, and it was a good game. So I do know that there's a red team and a blue team. That's all I know. Okay, so I'm actually going to talk about delirium. And as Brian mentioned in his first presentation, it's in acute care. This is the condition we need to treat as probably the priority condition. In acute care, you can talk about as many conditions that people may have cognitive impairment in. So we tend to use cognitive impairment. And some of that's to do with actually, sort of concur with Brian, is it's pretty hard to make a dementia diagnosis in acute care. So we have delirium, dementia, we have superimposed on each other, we have other intellectual impairment, brain injury, which make them more susceptible to delirium, and then mental health as well. So what is delirium? Can you hear me if I stand like this? I always bend over to the microphone. I don't know if you have that trouble. So what is delirium? So for those who are not familiar with delirium, it's an acute confusional state. We have changes in consciousness and cognition, decreased ability to focus and sustain and shift attention, which is why a lot of people who have delirium appear disorientated. Changes in sleep-wake cycles, and I always get really annoyed in hospital settings when everybody says they're just sundown. I really find that an unuseful term, because if we're talking about changes in sleep-wake cycles, people are up at night, and might not be because of some perceived disturbance due to dementia. We have up or down psychomotor behaviours. So there's several types of dementia. We have a hyperactive dementia, so psychomotor behaviours are agitated, restless, where you're getting in and out of bed, picking at things, pulling at things, can't rest, hypervigilant. And we have hypoactive behaviours. And then we have this fluctuation between the two. We might also see in the literature as subsyndromal delirium, which is fairly severe delirium going over a long period of time. It's poorly understood, the pathophysiology. We have a number of different theories about it, which I won't go into now, but it's probable that these are multiple areas of inflammation, brain permeability, are all working together, and there's not really one main theory. But it is prevalent, and as we've seen, like dementia, we're probably missing a lot of it. So we don't really know how much there is. But this is some figures in the hospital setting, and it is prevalent also in residential aged care, and as we were talking about before, probably in the community. So whilst I'm talking mainly about acute care, obviously we need to be on the lookout for delirium wherever it occurs. So multiple risk factors for delirium, and a useful way to think of it is that there's vulnerabilities, which is over on the left-hand side, and there's these precipitating insults. And the more vulnerabilities you have, so there's multifactorial. This is a condition that's multifactorial. It's hard to put your finger on one cause. So if you're more vulnerable, therefore, if you have dementia, you are in some glasses, and you don't have them with you, and you're not mobilising much, and then you get a UTI, then there's a good chance that you'll, well, probably if you've had dementia, there's a good chance you get delirium anyway. But if you're an older person with some of those other pre-existing vulnerabilities, there's a better chance of, or there's a higher risk of getting delirium. And age is a big risk factor. And there's this sort of interaction between the vulnerability and the level of insult. So the more insult, the more vulnerable you are, the higher risk you are of delirium. But dementia puts you at a very high risk, up to 5-fold increase in risk. And there is some speculation, because if you have delirium for a long time, for critically ill with dementia, you might then further decline in your cognitive impairment and not recover. Also, there's a couple of theories about whether delirium signals vulnerability of the brain to decrease cognitive reserve, putting you at a high risk of dementia in the future. So it's signaling that your brain is already fragile, so you're more susceptible to having delirium. And then there's also some evidence that says delirium dementia when it's previously unrecognised by having delirium brings into focus the fact that there may be an underlying dementia pathology. Delirium and dementia appear different. So I'll just talk about dementia, in case we don't know what dementia is. And it's a neurodegenerative stage over 100 different diseases, so it's actually a condition or syndrome. Progressive decline in language, memory, perception, personality, and cognitive skills, and that varies depending on the disease that's causing dementia. And at some stage, for a lot of people with dementia, we have these behavioural and psychological symptoms, which is one could interpret as when communication becomes more difficult, depending on cognitive or language abilities. In hospitals, we have quite a lot of admissions, and Brian's talked about how that works with dementia. They're coming in for other reasons, mainly. And dementia as a comorbidity it needs specialist care. So we've sort of got all these generalists on these wards, but there is some specialist care. Well, we need to understand that communication could be a problem. There's potentially increased agitation, sustained low and high stimulation activities. And that's really saying more about our environments, as we just heard about, and the types of things we do in our environment than a person with dementia. And dementia increases the risk of delirium for some people coming into hospital, behavioural psychological symptoms of dementia. And probably the more difficult ones for staff in hospitals to deal with is aggression, agitation, constant wandering, and restlessness. Brian's outlined that it's not so good if you have cognitive impairment, whether it be delirium or dementia, in hospital. You're more likely to fall, have adverse outcomes, and you stay in hospital a lot longer. It depends on the quality of your hospital and what you're doing. But if you have dementia, or if and some studies say that you have 3 times faster decline for people with Alzheimer's disease, say 12 months after you've come into hospital and had delirium. 6% of cases with prolonged delirium, and this is in people without cognitive impairment. This is when they're critically ill, you're in ICU, you have delirium for quite a long time. Sustained impairment 12 months after discharge, equivalent to somebody with a moderate traumatic brain injury or mild cognitive impairment, mild dementia. So that's a permanent, or not, it might become a later, but it's a long sustained change in cognition. So it matters that we pick up delirium. Increases likely functional decline, loss of independence and need replacement. And there's a lot, as has been spoken already, people are ending up in place because they have been, with their delirium and dementia, often wrongly placed because of delirium and being not identified. Associated stress for the person with delirium, the family and the care work is very stressful. It is often the sole manifestation of a serious underlying illness, and this is not in dementia, but if somebody is delirious, often your vital signs can be fairly stable, but actually this is the precursor. And the amount of times I have seen people who are delirious, and then 3 days later, or 2 days later, or 1 day later, or this afternoon, there's a code called, and we have a serious deterioration in the medical condition. And within 30 to 40% of cases of delirium may be preventable and treatable. A lot of cases are treatable. So looking at people being discharged, and I think Brian alluded to this before, people who are perhaps wrongly discharged to other facilities with delirium. That's 30 days, it's a study by Mark Montagnier. You can see that rehospitalisation is high, and continuing delirium is high and staying in the post-acute facility. So therefore, what are we doing in hospitals? I think is this your study, Brian? 47% people with known dementia wasn't picked up. I've read that somewhere. About 50%. About 50%. So we have people with known dementia coming into hospital. So, but no documentation that they have dementia. And when you consider 5-fold increase of risk, seems rather a big omission for us to be making. So we're getting something wrong about our thinking in hospitals. 65% of people, it's hard to detect. It seems to be hard to detect. There's delirium. 65% of delirium cases not detected by physicians in emergency departments. Physicians only recognising delirium in 1/3 of patients who actually had delirium in another study. That was in residential aged care. In a hospital study, 75% of cases were not identified by nurses in hospitals when using the CAM, actually. So this is not an easy thing for nursing staff to detect. And I would actually put it out there that nursing staff are not trained in cognition. They're trained in neuro things, doing a Glasgow Coma scale. They're not trained in attention, memory, any of these things in undergraduate courses. In fact, delirium and dementia are very rarely even taught in undergraduate courses, except as a little elective unit, which you might, if you're into aged care, go to the nursing home, elect to take for a couple of units in that thing. So I think we're preparing a workforce that's just not equipped for this. So therefore, people like us in hospitals are going, hey, we've got to equip ourselves. So there's a big problem there. And I know real estate's hard in nursing courses, but I think they need to really put that in the prime line. But also, it looks like in physicians' courses as well. 80% of cases of delirium superimposed on dementia are not detected, and that's got its own complications. So I'm a bit short of time because we're running a bit late, so I'm going to run through a few slides. But there's this idea that it's just a confused older person over there. And this is a case I've come across, where this confused older person was completely cognitively intact, living at home by herself, so no dementia that we knew about, doing all the things, and she got all those medications in 2 days, and was special, and had, incontinent, and she basically had hypoxia that was not picked up for 4 days. So this is happening now in emergency departments and acute hospitals. There's so much wrong with that. If she had dementia, there's so much wrong with that. Those medications are appalling. And it's just, they're appalling for both conditions. But I think what it does is, there's this, I've been rolling out education at the PA, and I've sort of done 800 nurses in AI in workshops. And the overwhelming response is understanding that there's a difference between delirium and dementia. Is that what they're saying to me? That was the first thing they put on their feedback, is understanding there's a difference between them. And we know that nurses, if they believe getting older is memory loss is a normal part of getting older, they're not going to really pick up delirium. It's just dementia. It's just older. If people don't believe that's a natural part of getting older, then they're much more. So it's just the belief systems even. Okay, so how do we find out delirium? Now this is probably one of the problems we have, is how do you bring in a screening tool? I'm actually speaking with to some of Judy McCroe's slides, who is going to speak today, and there's a couple of very quick screening tools that any person can ask. The one over here is Squid. You're really asking a carer or relative, asking them, have you noticed anything about Kirsty? Is she more confused lately? It's just one question, so it's a single question. And if there's a positive response to that, then we go on further to do something a bit more in-depth like the CAM. But as you can see from the previous slide, how many nurses are actually going to be able to do the CAM and actually achieve a result that's actually positive? And then gold standard would be there was a specialist looking at the diagnostic criteria down the bottom. So just to outline, delirium and dementia can appear different. Okay, there's differences in what we tend to look at when we look at a screening tools. We look at attention, so whether you're able to sustain attention. And we look at sleep-wake cycles. So you can see that. Just have a moment to look down one side and look at the other side. And I think when your question earlier on, sorry, the lady, your question about this is what a lot of carers are tapping into. They're noticing there's a difference to somebody who they know. They're different. They're not as attentive. They're going to sleep in the middle of conversations and all these sort of things. I'm going to talk about the confusion assessment method, but I'm not going to teach you how to do it, although the slides here sort of look like I am. But one of the validated tools, screening tools, is the confusion assessment method. And this is a shortened version, and we're teaching this at the, I'm trying to teach this to the nursing staff at the hospital. Acute onset, so you've got to have the first, there's actually 4 domains, if you want to call it. It's got to be an acute onset and mental stage with fluctuating course. You need to notice that there is an attention. You have to have those 2 domains, and then you have to have one of the next 2, which is either disorganized thinking or altered level of consciousness. And you do this by having a short cognitive interview with the patient. Oop, I think I'm not working. The other way. Just down.
Just across. Yeah.
Seems to do this in the middle.
Yeah.
So what this tool is validated for is to use a thing called a mini HOG test and a digit span test. But what I tend to tell my clinicians is the main thing is you're asking some cognitive questions.
I'm not sure what's happened.
I'll keep talking. And the first of all, you're asking, the mini-cog test looks a bit like, do you know where you are, how long have you been in hospital, what's the time, what's the year, those sort of things, why are you here. So some orientation. The second question is remember these 3 items, or say back to me these 3 items, Apple Watch penny, or Apple Watch table, some words like that in the register. You do a clock drawing test where you ask them to draw a clock and mark 10 past 11. And then you ask them to recall those 3 items. So that's what the mini-cog test is. And then the other test is a digit span test, which is repeating back some oh, you're moving on, we're back. So that's the mini-cog test, okay? And then the digit span test looks really complicated, but I'm basically going to say that, sorry, Kirsty, can you repeat after me? 1, 3, and Kirsty does that, and then she gets that wrong and go 1, 4, 5. It's just, you've got to have good attention, working memory to be able to do that. And people get up to about 6 or 7 normally, and then if you're inattentive, you don't do so well. The point is that in doing any of these cognitive screening tests, you're actually observing how somebody is doing the task required. You can get all the questions wrong, if you want to say that on the cog test, but you don't screen positive for delirium because you're not demonstrating that there's an acute onset and mental stages and fluctuations. This is a problematic one when you come to hospital and nobody knows you, and you're found sort of rambling around the park with your sort of media belongings that are all known to you, and you can't find out. So what should you do? I get people asking me, clinicians, well, you assume the worst, that they've got delirium until you prove otherwise. So you can put that down as a 1 if you want to. So there's some questions there. Other ways of looking at it, I won't read them all. Inattention. Inattention's a difficult one too, because all the way through the test, there can be demonstrations of inattention, just like fluctuation. But there's some count backwards from 20. That's beyond sustained attention on the task. I say to nurses when they do the CAM, the shortest CAM you'll ever do, or the longest CAM you'll ever do, is when somebody's actually cognitively intact and doesn't have to do it. Because you'll get through it. Because usually you only get through the first 2 questions on the mini-cog test, and it's quite apparent that there's inattention, acute fluctuation, disorganised thinking. So disorganised thinking, oh, that's inattention, sorry. There's some more examples. This is when you ask about one thing and get comments about another thing that's rambling into another thing. And then feature 4 is alter level consciousness. And when we seem to be picking up hyperactive delirium, but we seem to be really poor at hyperactive delirium. And perhaps some of that's because of the idea of sedation, or they've had a rough night, they're sleeping, and nobody wakes them up and actually asks them some specific cognitive questions. Brian alluded to the work that the, I can never say the full name, ACSC, and this is sort of, one of our issues is early identification of delirium when coming into a hospital. And this is some problem solving. So what's this space? But, does the person have a known cognitive impairment? We asking that question, we might go and search more than having 47–50% of people who have got a known impairment somehow get into a hospital without us knowing that. If you have a known impairment, you've got 5 times risk of perhaps having delirium. It's probably fair game to have some sort of delirium screening happening with you. Is there concern raised by the family or carers about cognition? Or is there concern observed from the staff about cognition? And then if you're over a certain age, you should have some cognitive impairment. And if you're under, you get treated, but then if there's changes in your situation. So one could say you could do the CAM once a day with young people, especially at high risk. Or when I think what generally happens when you're rolling out the CAM is probably the bottom is the default position. When there's a change, I'll do that. So even if we can get nurses to do that, we're doing well. But there's some issues with the CAM, as I've said before, not picking it up. And also there's a certain burden on being asked all these questions every day as a patient. So there's some other tools that have been getting worked on, and there's some there. Dementia seems to be more an observational thing. When I go and do my med rounds as a nurse, I'm observing how the patient patients doing things around me. Still going to have these principles though of inattention, disorganized thinking. But I have this in your head, thinking about that. And that's where I think some of our training, certainly in nursing, needs to focus. So there's some other tools. So I just talked about the CAM today, but there's other tools available and more evidence for validity and reliability, especially in the last 2 or 3 years. So what? So if we find delirium, the number one thing is to find the cause and treat it. You know, I talked about all those risk factors. Well, there's a lot. There's just about anything can cause delirium, you could say. But prevention is better than cure, and we can set up systems that are much more attuned, especially somebody who's at high risk of delirium, of monitoring for constipation, dehydration, fluid intake. These are the sort of the battles if you're working in nursing and like at a leadership level, you're constantly trying to battle with this anyway. All right. So are they hypoxic? Are they in pain? Is there infection? These are some common causes. And there's growing evidence that non-pharmacological responses and setting up preventative responses and having better environments is certainly one for people with dementia, that we can do a lot. And this is not rocket science if you read all that. But it is hard. Busy ward environment set up, it's a bit utilitarian, you know, input, output, throughput systems. I've got to get 4 people out, therefore I've got to get 4 people in. That's it, you sort it out, right? That's not what you're looking at there. But we can look at the environment, daylight. The amount of times I see a person with delirium, special, one-on-one, with the curtains shut, water and everything out of reach, the special sitting at the door and it's dark and it's 10 o'clock in the morning. Whereas we could be sitting out of bed, having a bit of an eat with the curtains wide open and getting, so these are the sort of things we're trying to get the nursing staff to do. So there's psychosocial things. We can have with orientation strategies, and those things will change depending whether the person has dementia or whether they are cognitively intact. But everybody can be orientated. You can just say, you know, good morning, Kirsty, how was your breakfast? It's an orientated conversation. My name is Fred. And then we're looking at the physical aspects there. And I'm hoping to concentrate on everything about pain before we get through this. So the evidence shows that we can do, in the hospital health program, which you might have heard of by Sharon and Lloyd, that's been running over the States, has a concerted effort. They have teams and they have volunteers that look at people at risk and go and do some of this stuff. PA were trying up on one set of wards a volunteer program where we identify people at risk. They're not got serious behavioural disturbance or anything like this. Just older people at risk of delirium and taking them downstairs for a coffee or reading a book or doing various things with them. The volunteers are there every day. We're just trying to measure how that goes at the moment. Pharmacological management is a bit more logic, but it's something I see every single day. People turning up to ED, confused, and getting a repairable infusion. These sort of types of management, there is a sort of, if you're looking at inflammatory markers and dopaminergic type of contribution in brain physiology, some people believe that medication could help with this in delirium. But at the moment, the studies are just not conclusive. The methodological problems and size of the samples and various things. So the first line treatment or preventative treatment for delirium really is not highly recommended for antipsychotics. Probably the best thing we can do is non-pharmacological agents and actually look at reducing psychoactive drugs. And attached there, shown anyway, I would argue there's opioids as well. Probably the thing about gerontology is go slow, start low and go slow. And only reserving those antipsychotics for extreme agitated events. Now, this is a real problem, I think, because that's a very subjective view. What I consider an extreme agitated event, because I work with people in this condition a lot, is very different from a nurse who's just come out on the ward in a new surgical ward and hasn't seen an agitation and somebody swore at it. So there is really different for what people will actually give, and I think this is a big issue. All right. What do we do with delirium when it's superimposed on dementia? We have these overlapping symptoms. Some, as dementia gets worse, we get more inattentive. The CAM is validated to be used with people with dementia, as is the dementia. But probably the key thing is ascertaining the baseline function from the carers. What does a person normally do? You can't do a CAM with somebody if you don't know what they normally do. And looking for acute changes. So if people say they're not normally this, they're not normally aggressive, they're not agitated, this is different. And the amount of times that we've had people come into hospital who are no longer walking, and they were walking two weeks ago, and then I get a report from somebody, a medical physician, saying we can't find a cause for the delirium, so this must be worsening dementia. So a sudden change in behaviour and function, I think that's a really lazy diagnosis. What they're really saying is there's nothing more we can do for them here, and perhaps they're better back at the residential aged care facility, which may have been true. But the fact that they couldn't find the reason for the delirium, and I've had this a lot, usually with junior medical staff, the fact that they can't find a cause for the delirium doesn't mean that the symptoms aren't indicating that this is a sudden change and that this is delirium. And what can we do? So we can communicate calmly and slowly. I don't know if anybody's familiar with John Flaherty's work in the Canadian hospital in the United States. Anyway, he has this video. It's worth having a look at. It's called Tolerate, Anticipate, and Don't Agitate. And it just shows you this sort of video of people interacting with a person with dementia who's got communication difficulties. He's very agitated in the bed, and how do you go about a normal assessment of trying to figure out what's wrong? There's a one where people are shouting at him and holding him and wriggling him and all this sort of thing, and then there's the one where we're all calm, we know the person's agitated, we're anticipating something, and it's a very different scenario that unfolds. And what I'm interested in is actually these, what we might call escalated behavioural events that sort of occur in hospitals, how much that is about the actual initial interaction between the clinician and the person with dementia, and not understanding how the world might be different. And it gets more difficult when there's delirium in the picture. Minimise medications, avoid physical restraints. It's really interesting to me working in an area that tries to avoid physical restraints, but then when one patient might have needed some physical restraint, suddenly the physical restraint occurs a bit more for the next month. On other patients, you've got to go. It's like this constant sort of wave of pull back. Why are you doing this? And there's other things that you can see there. We've got 5 minutes to go. So, they're up. Okay. I wanted to, a lot of those strategies there are these universal strategies we would hope medical clinicians are looking for and setting up. I think pain is a little more difficult, especially in delirium superimposed dementia. How do you assess pain in dementia is one question. How do you assess pain in delirium is another question. So we know treating pain increases the risk of delirium in patients regardless of their cognitive. Opioid use for pain do not increase risk of delirium in older. Several studies have shown this in pediatric patients, but narcotics did generally. So opioid use alone. So this is probably need to qualify that. When we get polypharmacy, we've got a whole lot of medications interacting. It's a different story. However, if you've got high opioid use and high pain levels, then there's an increased risk of delirium. So it's a controversial area, but multiple studies show that there is undertreatment for pain in people with dementia. This is related to not being able to self-report, different pathophysiological mechanisms about effective and sort of ways to respond to pain. So we have a loss of ability to communicate pain in many cases. Now, self-report is reliable. Somebody's telling you they're in pain, even if they don't remember they told you in pain. I would always trust self-report first. But I often see patients who are telling me, I don't have pain. You're trying to poison it. Go away. So there's delirium superimposed on dementia. Perhaps there is pain, because it's the only explicable, one of the explicable reasons we want to move out. And there's other reasons why we might not have pain medication. How many observational pain tools are around? Is anybody using an observational pain tool at the moment in their hospital? Professor Abbott in residential aged care? Yeah? Yeah. What's the reliability of only using an observational scale? and what are the best practices and protocols. This is a very developing area, very difficult because it's a subjective thing. So to go quickly through it, observational pain tells may overinflate because of the converging different symptoms from delirium, depression, dementia. Pain is always but it is associated with behaviours, and certainly interventions that have looking at pain and dementia have also had positive outcomes on BPSD. But it's very hard to understand the relationship. It's still being worked on. There is no behavioural observation scale for pain in delirium on its own yet. Some are being worked on, but haven't been haven't had enough trials yet. So best practice would say, considering all of that actually triangulation is the thing to do. Does the person have a painful condition? Is this new behaviour? Is this a different behaviour? Is it a painful treatment? And you get those other information from observing the patient. Do they have agitated and fluctuating systems, but also from the family and carers? And if so, try an analgesic trial. So that's the American Pain Association, the non-verbal position statement. So in our hospital, we had to choose a pain tool. There's a whole bunch of pain tools there, and there's many more. The best evidence is actually PAC Slack. But at the time, when I was looking at it, 60 domains to look at. It's going to be really hard to get every acute care nurse to do 60 domain tool. So this is one of the criticisms of PAC Slack. I do know, just looking through the literature last night, thinking about today, that they've actually developed one that's 27 domains now, which is a lot less and certainly worth looking at. Pain is one that's quick. There's some theoretical problems with some of the items on the scale, but it's being tested a bit in acute care, so we chose to use that. And in acute care, for myself, I wanted to have a graph, because acute care nurses read graphs. So the pain element scale is the verbal pain scale, and we've come up with a chart a bit like this. Now, it's a busy chart from that distance, but at the top we've got the Pittsburgh agitation scale, looking at general agitation, general sort of things like vocalization, motor agitation, aggressiveness. For the sleep row there, verbal pain scale and pain rate. And then we've got an intervention rows at the bottom. And obviously I'm better there. So this is actually somebody's chart who had pain. And the INs were all antipsychotics on that day one. So nobody had pain assessment, so we've got this person actually, some people do ED because they're getting hurt. And then after a couple of days of having analgesia, when there's escalated behaviours, sleeping more at night or getting a response. I suppose the point is if you don't have a pain assessment or any objective ways of measuring some of this cause and response, then you probably should get some. It doesn't have to be this, but otherwise you've got basically very anecdotal events of somebody moved last night, my night was hell, and etc. etc. In fact, they're just going off. There's just a sort of an incident at 2 o'clock every morning, and it's probably around the toilet. So we'll wait until 1:30 and we'll go to the toilet. But unless it's an objective measure, a lot of acute care nurses will just sort of have it as a very difficult cycle to pick up. All right. Some of these points have already been raised. The 5 things about me is actually the 5 top points. Underneath your chairs, you have a sunflower, I believe. We use a sunflower in our room, which is just a. Do you have a sunflower? Yeah, in your bags anyway. So you can put up information that, with the permission of the carers, person with dementia and the family. It gives you a snapshot, and staff will really find it easy to walk in and just start talking about, Cyril's pet dog. I would be very cautious of specials. I do think there's a role for the special and the dyad, but there is no gerontological evidence-based driving how they're used, and there seems to be much a resource management thing about money. I believe you can have a very good gerontological care if you use a good approach and have a team that actually delivers care, and that might mean that the specials only used for 2 days, but in that time they go for walks, we go and do recreational activities, we do a whole lot of other things that the nurse is driving. At the moment, what happens is an alien gets left to their own devices, and the nurse sits out here, and I believe really that that's because it's a complete lack of knowledge for the nurse what to do in the situation. And that's men, I believe. Watch this space from what Brian was talking about for more on delirium. There's some resources there. Is this available for people later, these presentations? Judy McCrae, I'm talking forward today, has a Learn About Delirium website at a QUT now. And leave you with those few points. Just common in hospitals, it's often reversible. We need to pick it up early, and we need to have resources and models of care that can actually support people with delirium. Thank you very much.
Thanks, Brad. All very enlightening and helping to build the picture of people's experiences in the acute care sector. Just a little bit of housekeeping stuff. We're about to go into lunch. I'll get back to you about the PowerPoints and how we'll make those available to you after lunch. So that we'll let you know how we can get that to you. Lunch is for half an hour. We run for till just about 12:45. We'll collect you all and come back to the room. We've got 3 other sessions this afternoon for afternoon tea. So before we go to lunch, I'd just like to thank our speakers so far, and also just take this opportunity to show Kirsty and Fred our appreciation of the small gifts. So thank you. We do hope to have questions later on today at the end of all of the sessions, but to also take the opportunity to meet with both Professor Draper, Fred and Kirsty during lunch today. Enjoy.
Report to the webcam over lunch.
Guys, all very well?
Yeah.
Tell them anyone's logged on. We're just testing anyway.
One viewer, but pretty much just testing anyway. Yep, so just that one that I've just opened for Fred.
It's a profile slide.
For login to some slides?
Yeah, I'm going to change the profile slide.
Oh, okay, yeah, I don't know anything about that. I've just put up Fred's second part of the slide. Kirsty's? I'll do that now.
Oh, his first one.
Oh yeah, I closed his first one. So Teresa's there, then the forget-me-not one, and then the final advertising. But Jason said he needs to log on and do something to a slide. Do you know anything about that?
Did he switch slide?
He said he just needed to log into Citrix to change some slide. I don't know. He said it like I should know what he's doing.
No, I'm too sure.
He'll do it. Did you leave me, Jason?
No, I'm just going to save this onto the desktop, and then I'll let you put it wherever you think you should be putting it.
Oh yeah, so this is just for after.
The last ones.
the
Yeah.
very
Do I
end.
talk this through?
No.
No,
This
you
is
just.
it rolls as people are leaving.
Okay,
It's sort of got on.
Oh, well, I didn't quite save it like that, so you might just need to open it and save it like a show.
Oh yeah, that's fine.
Yeah.
No worries.
Just thinking, do you want to put those advertising ones on? Popping around, I was coming in to take it off because I'd left.
Oh, yeah, no, I saw that. So I'm just, yeah, that's okay. I'm just having a look at Teresa's slides, and then, yeah, I can put the ad ones on. Teresa, could I speak to you? Sorry. Yeah. I'm just looking at your slides, and I just noticed. Oh no, that's fine. Number 27. So sorry for interrupting. I just noticed it says click to add title. Do you want me to delete that?
Yes, okay. I'm not very clever at any of that. I missed the last slide.
Hey, even when we've got champion baby people, things still happen. So I think it looks great. Oh, actually, yeah, that was the other thing. This one sort of, if I blow it up, this is what it looks like. I just don't know.
I thought it was went on.
Oh, yep, that's fine.
Yeah,
so it's just in the.
Yeah, just in the thing.
The thing. All right,
yeah.
cool. And are you right with the clipper, or would you like to use these?
I would rather use that.
So yeah, it's just the across one or the down one, but I go for the across because it's bigger. So
yeah, that's easy.
Yeah, and could you put me out to Danielle and Mandy? Are they?
They're the ones.
Yeah, they might be having lunch. When they come in,
yes,
I'll chat to them.
Okay.
And then Fred knows what he's doing, so that's fine.
Okay, no
Great.
smelly things as well, but I don't know.
Just check our slides. Yeah, I was going to invite you up, and my name's Bianca. Hi, Bianca. So we've got the slides are great. I love them. Really good. So you've just got them all. I was just checking that they're all on the mouse click. Would you prefer to use this one?
Is that okay?
Yeah. That should
And
be
it'll
fine.
stop halfway through, and then we'll just call you up. No.
Oh, I hope not. I checked with the AV guy, and he doesn't know what's going on.
Isn't that strange?
He says it
Halfway through.
never happens, but it's happening for us. So that's
good.
Yeah, it's good that we've got amazing people here who are patient with us. So you can click through if you want to have a double check, and maybe I can blow it up to the. Blow it up to the big
That'd be
one.
lovely. Thank you.
Yeah. And let me just check. Will you be speaking together, like
Separately? No.
Tonight?
So
Okay.
Danielle will go first, and then I'll go second.
Okay, that's easy. So yeah, you can both use this one. Oh, just go cancel.
Oh, I was just going to say, okay.
Yeah, I just cancelled before because the other one wants to block the pictures.
Oh.
So yeah.
So give these plenty.
Oh, great. Well, we'll hand them around. I'll hand them around at this point.
Good, how are you? Makes me nervous. Oh, really? Oh, yeah, it's nothing for them. I know it says freaky, but you open it up. It's like there's this spray, dementia spray. They're just a cheap way of increasing stimulation. Yeah. So, chopped chip.
That's good, isn't it?
Yeah. This one's caramel.
If all else fails, there's buttons.
Now, do I need to show that this is what the education, one of these books I brought two. So, fancy dementia.
Yeah. You want the live stream link? I posted it on our Facebook page this morning, so if you can access the Alphabet Straight Queensland Facebook page.
Well, we can access later if she has
On a regular basis.
Can you access it after it's presented?
Yeah, so it automatically records it. So what I'm going to do is have an email to everyone who RSVP and then say, just for your record, but also make it give them to record. So it's link to
Yep.
Did you want me to put some of those up here?
Yeah.
Yeah. So,
Yeah, so I didn't actually ask for it initially, but
there's another bottom level we can put in.
I just think it's probably easier if I just put all those things. It's typed out.
So, I'll leave them up.
That's not it out. Sorry. Do you want
So there's no way of myself. I'm going to be, sorry. I'm not until last, so I can bring all this up last actually. Probably. Okay. Yep, or you give some to me, I can help you carry them up. Yeah, because some of them are just for me to go like that, but others we're going to hand out in the crowd. Just as an example, so they can have a look. Yeah, that's great. Not to keep obviously, but they can go out. Would you like my help handing those out so you can keep talking? Or? Yeah, so I'll just talk about that and then just, so there's 2 lots of those, or Wendy said she could do it, but there's 2 lots. There's 2 lots. So, Charlotte, did you need something? I'll be right back. Yeah. I'm trying to figure out where to put all this stuff where I'm going to put it. What, do you want me to bring them up later? Yeah. Alright. Could have saved you the walk. I was trying to get it all prepared. I don't know what I'm doing, Wendy. What? You might make sure. So when you look at it, just going to say the one. Or just get 5 minutes. It's funny with this comment. Okay, well, let me go on. I'm just not sure what to hand those out. They're just an example of things that are on the survey. Yeah. And there's that's the slide. Then you say I've got 2. But they're also 2 pictures. And then I'm just going to
Yeah, they're in the thing.
Yeah, we mixed that. So slide 14.
It's probably still live streaming.
Oh.
Can you hear me doubling? No? Julie Elliott.
Then some of the units are different. It's not, you know, voice transcription, but is that an example of one unit?
Hello? Is that on? No? Okay, everyone. Just waiting for the last couple of people to walk through the door. Should have a raffle or something to get people to come back early. Okay, I think we'll start. Looks like we've got the bulk of people back. Okay, well, just for your information, we've been live streaming today via Google. Is that right? YouTube? Via YouTube, it was our first trial of streaming these sorts of events, particularly so we can focus on getting this information out into our regions, particularly Queensland. We've got the bulk of our people live outside of Brisbane, so the first trial of going live on YouTube. They didn't tell me that before I started. I don't know if they told me other speakers either. We'll have to fix that part of the process. Lucky we didn't say anything that we shouldn't have. Okay, so welcome back, and I hope you enjoyed some lunch, and we are going to see if we can get a little bit of daylight in here to keep us awake for the rest of the afternoon. Otherwise, I hope you have some coffee at lunch. Our next speaker needs no introduction to our staff and volunteers, having worked with Alzheimer's Australia Queensland for the past 2.5 years. But for those of you who have not yet had the pleasure of meeting Teresa Choi, I'd like to give you a short introduction regarding her. Teresa is a registered nurse who has 30 years experience in aged care, particularly dementia focused, across a number of settings. This includes community care, working as an RM, with the Sydney and Home Nursing Service, being a clinical facilitator with the University of Western Sydney, taking students into residential care facilities and acute care, and working as a clinical nurse specialist in aged care in the aged care assessment team, both in New South Wales and Queensland. Teresa's a much loved member of our staff who always goes above and beyond, including stepping in with less than 2 hours notice to our last speaking function. We gave her 3.5 hours for today, a couple of nights ago. So thank you, Teresa, for always being available to us. Teresa's coming to the stage now to talk to us about the Return Me Home project.
Good afternoon, everyone. I hope you did enjoy your lunch today. First and foremost, Chora is actually the shortened version of my name. So some people actually know that my surname is Horongzhichevsky. But, you know, if you ever get to speak to me on the phone, trying to say, good afternoon, Alzheimer's Australia, Queensland, DB Mass, Dementia Behaviour Management Advisory Service, Teresa Horongzhichevsky speaking. By that stage, you would have already hung up. So, sure it is, and DB Mass it is, and Alzheimer's Australia go. All right. What I'm actually presenting today is the Return Me Home program. I'll just read that across. We're actually going to be talking a little bit about who DB Mass is and the Return Me Home project, and I'm actually going to present a case that we assisted with moving or transitioning someone from an acute care facility back to residential care. Okay, so DB Mass, for those who don't know who DB Mass is, the service criteria and functions, basically the eligibility is for someone who's actually got a diagnosis of dementia or working towards that diagnosis. And the person with dementia and behaviours are actually impacting on that care. Now, DB Mass does go everywhere. When I mean everywhere, all across the state. It goes into residential aged care facilities as well as into people's homes. And part of DB Mass's role is to provide information advice about BPSDs. I think we've already heard Fred mention that, the behavioural and psychological symptoms of dementia. And we do short-term case management. So a comprehensive assessment is actually made. BPSD management and care plans are developed, strategies as we like to call them. We do some mentoring and modelling of behaviour management techniques, and we actually try and capacity build people who are caring for a person with dementia. There's no point in just putting in strategies when then the next time something happens, we've got to get a phone call again for something very similar if we're getting referrals from residential aged care. So hopefully we are building capacity in people. The last thing that we do is education. Our first and foremost priority is definitely to our clients as opposed to just providing education. But the best education is usually in conjunction with case management, because then you can see the difference and how things are actually put into place and it actually then works. So, DB Mass expansion into acute care. And I suppose the first thing I thought we might look at is what are behavioural and psychological symptoms of dementia. Some of the most common ones are actually there on your screen. I'm not going to go through all of them. I think most of us have actually had some exposure to those BPSDs. And Alzheimer's Australia DB Mass are saying that a BPSD, a behaviour and psychological symptom of dementia, is an unmet need. It is communication by the person with dementia telling us, and excuse for my singing, something's missing in my... Okay? So, I often say it is also a feeling that causes the behaviour, not the behaviour causing the feeling. What we mean by that, or what I mean by that, is if I'm hungry, I'm going to search for food. If I'm thirsty, I'm going to go and try and find some water. If I'm lonely, I'm going to go and find companionship. If I'm scared, I might lash out because I don't know who you are that's coming towards me. So behaviour is a response to external stimuli, as well as sometimes it can be an internal stimuli that does it. Okay. In 2012, DOHA, or the Department of Social Services, I always want to say Social Security, you can tell which era I was born in, can't you? The objectives was that there was an acute care, primary care project through the Living Longer, Living Better program, and the idea was to reduce admissions into acute and residential aged care facilities and reduce those length of stays in hospital for a person with dementia. We've already seen that adverse events can happen when people stay in hospital for over a long period of time, and we're trying to reduce care burden and overall costs that it costs to actually care for someone with dementia. We're also looking at a timely diagnosis of someone with dementia and improve that person's quality of life. Not only the quality of life of the person with dementia, but also the carer. Part of the project was supporting and educating everyone and anyone, the general public, the actual person who is caring for someone in an acute situation, the opportunity for preferred accommodation at the end of the hospitalisation stay, and preferred access to DBMS. So there was a scoping project done. One of my co-workers, Lois Eastgate, with another co-worker, Lucy, and I can never remember her surname, and I do apologise, Lucy Hibbert Foy, that's right, thank you. I do apologise, I can never remember her name when I need it. But they did a scoping project to find out the most common BPSDs that were actually seen in acute care. So they divided up into two sections. Behavioural symptoms was agitation, wandering and resistance to care. And the psychological symptoms of dementia, part of those were anxiety, repetitive questioning, complaining, and delusions. I'd like to know what sort of complaints were there. And the acute care sector was saying that BPSDs, the hardest to manage were wandering, resistance to care and physical aggression. And the psychological symptoms were anxiety, delusions and hallucinations, sleeplessness, interesting, and catastrophic reactions. I think that goes in with Fred's talk, where perhaps that sleep-wake cycle has been changed due to a delirium, but it was defined as a BPSD. So out of all those scoping projects, the key outcome was this Return Me Home program. So since July last year till about, I think it was about May this year, there were 27 clients that were part of this project across 13 sites across Queensland. And some were Queensland Health in the metro region. There was 4 from their inner regional Queensland, a Queensland Health facility. This is acute care that I'm talking about. There were 3 clients. Outer regional were 3 clients, none from rural. We didn't have any referrals from them. From remote Queensland was 1. There was 1 from a private hospital in the metro area and none from the non-metro area. Does that make sense? Okay. And Dr Connect is the website that we looked at from where the different referrals actually came from to determine whether they were inner regional, outer regional, rural, remote, etc. Okay. So the reason for admission from a residential aged care facility to the acute sector, there were 13 altogether, and the reason majority of the reason 12 of those 13 actually had a BPSD. So a facility couldn't manage the behaviours, so they ended up in hospital, in an acute hospital. One of the reasons a person with dementia was admitted to the acute hospital was a fracture. So there was only literally one thing at that point in time. Reason for admission from the community to the hospital sector, there was 14 clients altogether. 7 were actually admitted with a BPSD. 2 had fractures, respiratory tract infection, CVA, mental health. Some just needed some social support because maybe the carer wasn't able to care for them any longer for whatever that reason. And the other was an unknown because we didn't quite get that full information on admission. The interesting thing was that if you can just think back to the slide of how many actually went from residential care to acute care, that there was only 13. But yet 17 went to a residential aged care facility after discharge of their admission. Again, sometimes we weren't actually told where they were going. 2 returned back to community. 4 went into subacute care, so it could be some sort of rehabilitation, and 1 still remained in hospital, or a change in hospital. As I said, this is research that I wasn't actually privy with, so I'm just presenting it for Lois's behalf, who's down at the acute. I think there's another acute conference down in Melbourne at the moment. Okay, the difference in the BPSDs at referral, the majority, we're calling it main BPSD instead of primary, even though primary is actually the terminology that the department is using, and second BPSD as opposed to secondary. But the most substantial BPSD that people were admitted with was physical aggression. And the most second BPSD was wandering. So we can see those things have a major impact on facilities or people out in the community. Okay. And this is just a bit of a brief breakdown of what type of dementia people actually had that were actually admitted in the project. We've got unstated, there's a lot of unstated diagnoses of dementia. So it's then hard to put them into a category, but we know that they've got cognitive impairment. Okay. And what was the outcome of those 27 clients? We actually provided strategies in acute care for managing BPSDs for 20 of those clients. And some of those 20 needed assistance going from acute care back to where they've actually came from. Some did not actually proceed, 3 didn't proceed with our interventions, and 3 ended up with no placements available for them, so they stayed on the, we discharged them from the program until such time that a placement was found, and 4 actually ended up being readmitted into acute care. And that was because 4 of them actually had an exacerbation of their BPSD. So that was quite interesting, I thought, further down the track. So they went into care, and 4 were readmitted to hospital because of their BPSD. And the new, and 1 actually had a new medical issue. I think they had a fracture. So this is the interesting part that I know a little bit better, so hopefully. Is everybody all right and comfortable? Yeah? Okay. All right. Just making sure. I am a nurse and I can fluff up pillows. No? All right. Okay. Statistics are sometimes great, but then statistics sometimes can be overwhelming. So this is the nitty-gritty of it all. Okay. So this is a gentleman that I know reasonably well. He was originally, we'll call him Mr. MJ. Okay. He was originally referred by his wife in June 2013. He was 72 years of age. He lived with his wife. He did actually have a diagnosis of Alzheimer's disease. The geriatrician actually suggested the wife make the referral to DB Mass originally. He also had high cholesterol and depression. The BPSD that the wife was having some difficulty with was verbal aggression and agitation. He constantly shadowed his wife, and he was very, very repetitive. And one of the biggest things for this gentleman was that he was told to stop driving, and he didn't like that. And his wife took over the driving. She just recently ended up getting her licence. So needless to say, he wasn't necessarily a back seat driver. He was more of a front seat driver with his wife. So he attended community respite because his wife actually worked. And when she wasn't around, Mr. MJ would look for his wife constantly. So, and he had difficulty expressing himself. He had dysphasia, and so he, you know, when we were doing the original interview with him, he and his wife, he would actually look for his wife for the answers to the questions we were asking. He loved going for walks. He had an ACAT assessment for high care, both for respite, permanent, and a package. So on the original assessment, some of the strategies we suggested, myself and another DB Mass consultant, was perhaps start organising a life history for this gentleman. And because if a package of care was to come in, then maybe they've got something that they can work with him as well. We also looked at perhaps doing an activity schedule so he can visualise what he needs to do every day. And so we quickly got that started. We talked about the 12 top tips, and you've got one of these in your bags. And there was a follow-up call to the service provider who was to look at putting in a package of care just to see whether or not things were proceeding ahead. 2 weeks later, he wandered off. He loved walking. Was found by police. He started, so therefore he went from his ordinary community day respite into a dementia day respite. Initially, that worked exceptionally well. The problem was on one particular day that what had happened was that the normal person who used to greet him at the door every time he came in wasn't there. And so he started becoming verbally aggressive, both towards his wife as she was about to leave because he didn't know who this person was, and he constantly would be aggressive when she was driving the car. Dementia Day Respite told him, "Don't want you back." He had abused staff and he'd actually hit another resident. When taken to the GP, they found nothing wrong with him. But whilst doing some chores one day, the package had already started, Mr. MJ disappeared. The service provider had not got the message to say that they didn't need him, they didn't need the person to pick up Mr. MJ for his daily walk. And so what happened was they went off. Mrs. MJ didn't know he had gone, so the police were called, and then eventually they found him with the carer. And so things like Find Me Watches, tracking devices were suggested, and there was a follow-up visit arranged to look at other options. So, but the wife decided that it was about time to start looking for permanent placement. I know that there's a long story that I'm giving you, but there is a reason why. So in the interim, he was to access residential respite to reduce his wife's burden on care. They found respite, Yahoo, but it wasn't successful. It only lasted a number of hours because of physical violence. He knew nobody. He was placed in an unfamiliar environment. So therefore, he was then transferred to an acute care facility. He didn't know anybody. He's moved from community to residential respite to now an acute care facility. 3 changes in a very short period of time. I did actually suggest to his wife that she take the life history with with her, and some personal effects to help settling him even in the hospital. So just to give you an example of what the Return Me Home program has actually helped in transitioning this gentleman. So a new referral was then made to DB Mass in January 14 as part of the Return Me Home project from the acute care sector. We have a new process where we have commitment letters that the acute care sector actually sign, all the key people, and we attended an initial visit with the staff there, and we did what we call a goal attainment scales. And we looked at what goal was to be achieved for this gentleman in trying to get him a placement in a facility. And we also put in a wellness plan. So the key staff worked to develop strategies built on their knowledge and my knowledge, because I had already met this gentleman previously. So with the two of us, we developed specific strategies in trying to be able to find an appropriate placement for this gentleman. So we sent out a whole heap of resources. The sunflower, for those who haven't seen it, looks like this. It's in your, and it's things that we all talk about, the sunflower, life history wall poster, life history, this is me template, so people can have an understanding of who the person actually is with dementia. We looked at the 12 top tips again. We looked at behaviour, we sent out behaviour monitoring tools. And any information that I actually had that would make that transition easy about what I knew about the resident, that would make it so much easier. They wrote up a profile and behaviour management strategies in the acute sector and for the facility. There was a lot of negotiation to try and find placement because of the previous history of physical violence, verbal aggression. They also needed to negotiate with DB Mass intervention. We cannot work with a residential aged care facility if they do not wish us to be involved. So again, a commitment letter was signed by the facility, and Mr. MJ was actually moved into care. The transfer itself went quite smoothly. We had anticipated what could be some of the problems, that he could not want his wife to drive him, so let's find a different alternative method of getting him to the facility. And the whole time we were liaising with his wife and with the facility to make sure that strategies that were given had been put into place and that all the written plans were being implemented. A few days in, unfortunately, some verbal and physical aggression resurfaced, and because of that, the wife was significantly distressed, thinking, oh my God, he's going to be moved out of there quickly. So there was lots of phone support to the facility. The wellness plan and the client profile was read by all staff who were to provide care for Mr. MJ, and this provided clues to minimise his actual distress. So basically that the staff could intervene prior to behaviours escalating. They could see when the distress or agitation start, that's the time to intervene, not when it has escalated to physical violence. Over a very short period of time after that, Mr. MJ's behaviour incidents resolved because staff were aware of what his needs were. So the overall outcome of this transition or Return Me Home program was the importance of all the early information and importance of the family knowledge. They're the ones who know the client, the resident, the person the best, and we need to work with them significantly. And we had to work with the wife so that, because she was actually impacted quite considerably about all the changes and her guilt about what her husband had been doing, and working with the acute care sector to obtain the best outcome for Mr. MJ. So lots of negotiations between family and hospital for placement and supporting them, and definitely Mr. MJ's needs were actually met and he was settled. So that was basically the whole outcome. It was all about person-centred care, negotiation, as well as just finding a happy medium that everybody would respond to, and I think that it was a very good outcome. DB Mass did a follow-up visit when they were in that particular area and did some further education. So that's it. It was a success story, and we have quite a few other success stories as well, but I thought I'd share that one with you. Thank you.
Thank you, Teresa. As always, we learn so much from you, and I think next time we'll try and give you an hour's notice to see how you go on that. Okay, next up, and sorry, Fred, you've only got 15 minutes, but you're not a football watcher, and all of us want to get out of here on time to make sure that we're home for the game tonight. So, Fred's coming out to talk to you about the subject is very dear to his heart, improving nursing knowledge and practice across a large hospital.
I must say that we haven't finished measuring or started a lot of measurement for this, but I suppose something that Brian said earlier on in his presentation was a lot of this stuff has been done, whether it's in residential aged care facilities. There's a lot of, as you've heard, about environmental design. We could well be doing that in our hospitals, environmental design. So I'm just going to share with you a bit about what we've been doing at the PA in this process, and as the information keeps coming about what works and what doesn't work, we've been modifying. And also, if I have time, I'll see how I go with my time management. A bit about my research, PhD research. So I'm interested in nursing, and I think there is a fair bit of more work to be done about this, but at the moment, the literature review on nursing around, I suppose if you want to look at acute care management of people with dementia, it was found that there's just inadequate knowledge about dementia and delirium with nursing staff. Okay, there's a few models of care, like nursing mid-range theories, models of care that are in place in acute care hospitals that involve nursing that have been tested in hospitals. Some good ones have been tested in residential aged care facilities. So why aren't we using or attempting to use them and measure them in hospitals? Nurses' beliefs about memory and aging affect their clinical decision making. I sort of alluded to that with delirium. Certainly there's some studies with McCarthy over in the United States in 2003 and 2004, did some grounded theory analysis of why, of critical decision making and beliefs. There's an overuse of chemical and physical restraint with very little regard, and I have to say this, very little regard to the serious side effects. And I would have to say also that nearly every nurse I talk to, and not all of them, do not know the side effects of antipsychotic medication in this population group. And that's quite startling with what I see is stuff that's goes out first line treatment. Freeing up time. I don't have time for this. I'm going to give you haloperidol. Against all the guidelines for prescribing, but it's written up. Medical he doesn't have time to deal with it. He does. This sort of dynamic exists. There's poor knowledge, as I just said. And I would also say there's some greater issues, and maybe something for the whole healthcare community, of this prioritisation of safety versus dignity. And I'll say that from the point of view, if you look at restraint use, say, in hospitals, putting bed rails up in hospitals, everybody still puts bed rails up. We know they should be down. We're putting bed rails up. We've got to keep somebody safe, even though it's not safe. At some point, when you allow people some dignity and freedom and creativity in the environment, you have to bear the risk that an adverse outcome might have. Somebody might fall, somebody might hurt themselves. So it's that balancing of what's a safe design, but also dignity. We sort of know that with people with dementia, and probably impairment, the more dignity and freedom and creativity, the more the environment is more suited to you, the better you go. So when we constrain people, restrain people, all these sort of things, it's a problem. So I like to get my own hands walking people outside in the garden and getting some sunlight and going for a picnic in the outdoor garden in the middle of the place, you know. And if you're special with somebody, then you've got time to do it. Off you go. If you're worried about you getting out of hand, you put a phone on your belt and you ring somebody for help. Nurses often feel, so what I mean by that is you've got to start thinking creatively and flexibly. When you grow up in a nurse in a hospital, it's utilitarian. Throughput output. Everybody's thinking throughput output. How to get my meds done, how to get my arms done. So it's about thinking differently. And so a lot of nurses say, I don't have time to do that. It's too hard to do that. All this sort of stuff. And I would challenge a lot of them on that. Well, what do I have at the end? And yes, when it's not going so well, you feel helpless and stressed and frustrated. You know you're not doing the best job, but you don't know how to get out of it. I would say that's often the response that hospitals do from a nursing point of view. We tend to put a one. Our least trained staff member in there, and there's no model of care. I've had AINs walking in telling me they got in trouble for asking the nurse for a handover about the patient they're walking in with. I kid you not. And I would challenge nearly every acute care facility tends to do this unless they've done some great work for it. That doesn't happen. I would challenge you that does happen. And also these false rooms ideas. 1 AIN amongst 4 delirious patients. You're asking for trouble. You know, I mean, you've got to have a bit more in place than that. This idea that 1 AIN can stop everybody jumping over the bed runs at once and getting fractured knots. This idea, you know. It's got to be a little bit more focused and a bit more assessment and things in place. So I don't think they reduce agitation generally, and not necessarily we know. We know specials actually increase custodial care. You sit there watching somebody, but not somebody the other day, because there was a big guy sitting there watching him through the doors in the middle of the night, the other guy got up and beat him up 5 times. Didn't have another problem with that guy. It was just that one big guy looking through at you when you wake up startled and you've been in the army all your life. That sort of thing. So what are we doing? How much time? Another 14 minutes? 5 minutes more important. Okay, so we've had at the PA. I'm going to take you from outside looking in. The actual journey was from one point of the hospital going out. So there's some possible things. You looked at some possible things that we could do as a hospital about improving care. Because a lot of this, I've seen lots of guidelines, and it's like make sure people have got pain and adequately treat for pain. It's a big job to get all your nursing staff to assess pain in somebody who doesn't self-report. It's a huge job, huge job. So, and it's a big job to get people to stop giving you haloperidol or grabbing the nearest thing that they can find, because there's nothing. I remember when I started, well, I haven't been nursing that long actually, but when I started there was nothing else. Nobody was telling me what to do, and there was nothing but antipsychotics and folding up glues and things. So, we're sort of looking at a whole bunch of things. We've also in our hospital got a geriatric service, so we have geriatricians available. They see our patients, so when we make calls to do so, and anybody getting ACAT'd out sees them, so we've got some of them here from the nursing side. We have a site liaison service, so we're lucky. We've also got an interface with residential aged care facility service. And we have an education website about dementia and delirium. We've got some policy and procedures, mainly we've got one for highly escalated events where we've tried to embed some of our other things, our other resources. Ooh. And we've got a specialist clinician, which is now me. And it seems to make a difference. We just heard this morning that having a special clinician and specialist aged care services can make a difference in your hospital. I've only got 4 minutes, so I'm not going to give you the theoretical perspectives as I was going to, but reconceptualising leukemia, but this behavioural and psychological symptoms of dementia is a new term, really, from 2002. But in the past, back in the 1980s, we've tended to look at dementia with a sort of a biomedical approach, which makes it a little problematic when you're trying to deal with behaviours, because it's something going on here, therefore you tend to go down a medication sort of line in trying to control the behaviours. So Paolo Lawton sort of conceptualised that there's an environmental fit theory. So there's environmental stress and there's cognitive competence. And as you have dementia, your cognitive competence gets lower and the environmental stresses are high, which I think acute care is high, then you tend to have an maladaptive behavioural response. So you have a behavioural response to this fit. So the job is really about maintaining your competence and reducing the environment, and you've heard how we might do that from environmental design. Also, around the same time, in the late 80s and 90s, there was a fellow called Tom Kitwood in the UK who was looking at valuing personhood and this idea of intersubjectivity. And as you get dementia, you need these relationships and interactions with people, and as it gets harder to do, you become more solitary and isolated. So when people hold your personality for you and interact and respect you, you have a better outcome. So these two ideas have fed into a mid-range theory for nursing, which is the needs-driven behavioural model, which is Professor Elizabeth Beattie, who some of you might know, is one of the authors of this model. And it incorporates that environmental fit theory. It's sort of saying there's a psychosocial, physical, and neurological component to understanding behaviour. There's these background factors that people have, and as dementia progresses, the neurology progresses. Okay, so there's different deficits that people have with communication or looking at the carpet and not wanting to step down that great hole that looks like over there, and all these sort of things. There's cognitive factors, health status. They're fairly stable, these factors. Nurses can't do a lot about them, but we need to understand they're there. But then there's these proximal factors that which affect or are less stable. So there's personal factors, physical environments, social environments. So it affects behaviour. So this mid-range theory has been well tested in residential aged care facilities for looking at environmental determinants and physical, all these different determinants in the proximal factors and getting a better outcome with some behaviours of so our nursing staff, this sort of thing. So we'll rush through this because we didn't really want to talk about this in so much depth. We're also looking at delirium and some stuff you can do for both conditions, delirium and dementia together, is in the middle. And we've sort of covered that this morning, really. So we wanted to educate our staff. It's hard to bring in all the different various websites and have your own tools and stuff. So we developed a module module for educating staff, and we cover all those topics there and incorporate the tools that we already have in the hospital. And then we send everybody out, if they're so desired, to go and actually do an online course through Tasmania or so in dementia. We've educated about 800 of our nursing staff now. And that also includes a 2-hour workshop in teaching the CAM and using the behavioural BPSD model to look at case studies. Well, we need some resources on the boards. So we've got the CAM. How do we want the CAM? Another form is hard work. So I've been teaching the CAM is just using a lanyard card. It's like doing an MSQ, right? It needs to be part of your practice. You do it, you write it down whether it's positive or negative. That's a work in progress that we're trying. Also, as I've said, we've got a behavioural observation tool, but we also promote using the ABC model as well, which is antecedent behavioural consequences, because this just looks at frequency and duration and intensity. But other events are trigger events. The fact that I come up to somebody and touch them without asking their permission, they're hypervigilant because they were in the wall and they punched me, is probably something I need to know about, and I can write that in a different way. We've set up a high care area where we've reduced falls by 30% in the population from the 3 wards, and we're still trying to measure some of our outcomes there. So we've got an environment, and in that environment we have a more focused model of care with higher staffing ratios, and we can sort of have recreational therapeutical activities available for people. And out of rolling out the education, a funny thing happened. I'm nearly finished. 1 minute. All right, I'm not going to talk about my PhD. But anyway, a funny thing happened. Maybe perhaps an unexpected thing happened. It was an opportunity to pull together cognition, what I call cognition champions. We didn't want to really call them dementia champions or delirium, because everybody can be impairment. And we found that people who were doing the education, some of them was like a light bulb. Oh, I really want to do more. So we've recruited 110 champions across the hospital, got a couple here. And for me, the idea is that they're going to bring about these changes. You know, a seminar, we had people from environmental, Richard Fleming's group, to talk about environmental change. So we're going to do a whole lot of different things, and we're going to build resources. Bearing in mind that actually the model of care, the theoretical basis, is the most important part of it all, because you can get into these little gimmicks. And part of that we're trying to embed is it's a professional practice model, so that they're going to become an expert clinician, go to professional development, and be a change agent. And the sort of things is they set up cognition corners on every ward that makes it visible. So, and then there's the resources, the modules, the sunflowers, the activity boxes, all these things, and they're going to look different on every single ward. So there's one, not much real estate there. So, but there's still something there, right? We had the sunflower chart that we were using in our high care room, and that's just laminated, right? So it can be on any ward, you can laminate more. And when somebody comes in, you ask the permission of the family carers, you can talk to people about things in their life. It makes a huge difference. Signage. A couple of our staff made an activity box of things to do with people with delirium and dementia. There's knitting, all sorts of stuff, and the volunteers are knitting up these fiddle aprons and blankets. And of course, if you're going to make stuff, you've got to protect it. Big barrier. This seems so elementary, but this is a huge barrier to anybody building anything in a hospital. Doesn't go to the laundry, or goes to the laundry and never comes back. I'm not going to do that again. Right? So that is a really important part of implementation. So we've got these boxes rolling out, and then we built these IVC aprons and IVC decoys, bearing in mind that just basically, you know, you can hide things, you don't have to have these things on, but when all other things fail, these things might work as well. So in the IVC apron, I don't think they work, but I've seen them work really well. There's things you can go into the pocket and pull out and play with, and sort of pull them out instead. And really, the best thing is to pull out an IVC as soon as you can, but if you've got, you need to have one in for the acute care, and the same thing. So there's some things that we've been doing. Our volunteers have been sewing marvellous things. This is a cover for a table. There's our lovely volunteers. They do very good work, I would suggest. And I think that's probably where I should leave it, bearing in time. So we're a work in progress. We'd like to measure the effect the cognitive champions have and how well we can embed the care, because they're going to try and help us do that. And I suppose one of the reasons this sort of started is I'm a CNC for delirium and dementia, and there's 800 beds in my hospital. I'm not going to see every person who walks through the door with delirium and dementia. I'd be exhausted. And why do nurses not think that they have to have at least some basic knowledge about this? So it's about improving the environment at a basic level, so that I'm seeing the people who I need to see, and everybody's actually. And I always say to them, you're going to deliver better care to everybody if you take on all the principles about dementia care. Anyway, there's a little snapshot from what we've been doing.
That's great. Sorry to cut you off. We'll have to get you back for a 2 or 3 hour session, and we'll give you a couple of days' notice. But it's such a great inspirational talk. I really loved those ideas for the IVs to stop them from coming out, and even getting your real estate in each of the wards. So fantastic ideas. Okay, so next up we have 2 speakers from Victoria who are here today to talk about their Forget Me Not project. We've got Wendy Hall, who's an occupational therapist with more than 25 years experience in various aspects of occupational therapy practice. She has extensive experience in designing interventions and meaningful activity programs for people experiencing behavioural and psychological symptoms of dementia. She has a great interest in the role of the environment plays in BPSD, and the skills and experience in creating dementia-friendly environments and garden spaces. In her private practice, she consults in all areas of dementia care, including home-based functioning, mainstream aged care and dementia, in the context of intellectual disabilities. She has a strong interest and passion for the use of occupational-based approaches in enabling functioning in dementia care and managing BPSD. She's a skilled educator who enjoys making learning evocative and practical. Wendy is employed as a behaviour consultant at the Dementia Behaviour Management Advisory Service in Victoria, and is an honorary lecturer in dementia care in the academic unit for psychiatry of old age at the University of Melbourne. She has extensive experience and interest in the management of BPSD using non-pharmacological approaches. Joining her, we have Danielle Harris, who's a lifestyle accreditation coordinator at St Vincent's Hospital, Melbourne. Danielle is a recreational therapist who has worked in the aged care industry for over 15 years and has experience in general aged care and aged mental health. Danielle's portfolio includes leisure and lifestyle programming in both mainstream and psychogeriatric residential facilities, education and environmental modifications. Danielle has been involved with several residential projects which were awarded Better Practice Awards in 2012. The projects that received awards included the development of Tranquility and Sports Garden and the creation of a residence shed, both in a psychogeriatric facility. Danielle is a consultant recreational therapist for DBMAS also, and has been involved in the hospital expansion project in Victoria for the past 12 months. Please put your hands together for Wendy and Danielle.
Well, that's the time up now. We'll finish up then. I think that went up for ages. There we go. Thanks for hanging around. They say last but not least, I hope, we're going to go along with a lot of the themes and a lot of the wonderful work that's also been discussed and just take a little bit of a different approach. Basically, today we're going to tell you about how DBMAS Victoria approached the hospital expansion project pilot, I suppose, that we ran. We're going to talk about why this project was so important, and that again is reiterating what everyone else has said today. What are the aims and key elements of our project, the research that was conducted on our project and the results that we got, how we took this approach and why we took the approach we took, and obviously with a bit of listening to our bios, we're going to be focusing on our occupational engagement and management of BPSD, and we're going to have a case study to sort of hopefully illustrate how we do that. So I'm going to hand over to Danielle.
Thank you, Lindy. Thank you all for lasting the day and staying. Just a brief background on the hospital expansion project. As Therese had mentioned in hers, there was the Minister's Dementia Advisory Group Dementia and Acute Care Forum report recommended that hospitals need to improve the care and management of patients with dementia and behavioural and psychological symptoms of dementia. Almost 30% of people in hospitals have a cognitive impairment, and people with dementia have a significantly higher risk of death, placement into long-term care, readmission to hospital, medical, surgical complications, and a longer length of stay. Our project was in line with connecting DBMAS into the acute sector, funded by the government, and it was about building the capacity of hospital staff to improve the care and management for patients with BPSD. Key elements of our project included that we had a hospital executive commitment and leadership. So the commitment and leadership came from the top down and filtered through the hospital system. We had executive sponsorship. There was a project manager for the hospital expansion, acute expansion project, a project coordinator, and key staff that worked in the acute sectors were identified. There was an establishment of a project leadership group, an establishment of a project steering committee which monitored the project's deliverables and the directed communication strategies in which we were going to take. We established, we connected with an already existing, established and sustainable whole of hospital volunteer program that was currently being that St Vincent's currently have. So we connected with that existing volunteer program to train volunteers for our program, which I'll speak about later. Terms of reference were developed, reporting structures determined. NARI has evaluated the program and the processes pre and post. Gap analysis and scoping of the nominated units to define key elements of the project approach were done. Each unit in which we worked with had environmental audits conducted, and recommendations and considerations for recommendations to put towards capital expenditure for the following year were made to the units, and they have all access to those environmental reports. The identification of key staff to take on a dementia leadership role and mentor and train existing staff, and using the tools in which we gave them was also done. Moving on. Again, other key elements included training and developing staff skill in dementia and managing dementia. We partnered with the Dementia Training Study Centre and Australian AAV to do our education, and the modules were done from the Dementia Training Study Manuals. We targeted ongoing education opportunities for key staff and volunteers. Not only did the staff get education, but we also did extensive education with volunteers around cognitive impairment, how to identify different types of cognitive impairment and how patients would behave or could behave in front of them, as well as extensive education on activities and how activities can be used with patients to engage them in meaningful activity in order to reduce behaviours. I was employed as a consultant recreational therapist who assisted with mentoring the staff and volunteers around activities. So yes, we'll move on to the next bit. So the recreational program, it was established to deliver a person-centred diversional therapy program for the hospital. This program would have to be sort of mobile-based and one-on-one, as a lot of the staff don't have time to be running groups as I would normally be running in a residential care facility in an acute sector. There were recommendations of equipment that supported meaningful engagement of patients with dementia and behaviours associated with that. We had specialised support for the staff and volunteers on how to use the equipment, and we still offer that service as well. We developed a lot of resources specific to managing different BPSDs with activities. Here's a guide that I'll get Wendy to show around, and also guides on recreational therapy information sheets that would hang off the trolley. And the development of a la carte activities trolley. As you can see here, this is the concept, the a la carte activity trolley, which is available for staff and volunteers to use on each of the units in which we worked with. And that is supplied with a lot of different equipment that was appropriate to our client group at the hospital. So that's just a picture of it. It is in a variety of different colours depending on the unit as well. So the role of the staff and the volunteers, the nurses would complete the Forget-Me-Not. Now our Forget-Me-Not originally originated like the sunflower that everybody has been showing today, but based on staff feedback and volunteer feedback, it transformed into a Forget-Me-Not. The staff wanted it to be made very important that, you know, a Forget-Me-Not was more connected to this is who I am as a person. Don't forget these elements of me. I'm a person, not a person with dementia or a bed number. And then that transformed into volunteers wanting to be called the Forget-Me-Not volunteers. And you'll see the badge that Wendy's wearing, and all volunteers wear that badge if they're involved in the program. So nurses complete the forget-me-not, which is a mini social profile of the patient. They assess the risk of the engagement with the volunteers. The nurses and the allied health carry out activities with the volunteers to manage the behaviours associated with dementia regularly, as well as volunteers do that on their own as well, based on whether or not a client is appropriate. Nurses provide volunteer handovers, they liaise and support the volunteers whilst they're on the units, as well as debrief. Oftentimes volunteers will experience something on the unit that might be unsettling for them, so that whole debrief process with the nurses prior to them leaving is a very important part. And they consulted with DB Massivic when and if required. The role of the volunteers was to work with staff to provide person-centred activities and friendly visits to patients, assist with providing appropriate activity items to patients as identified on their forget-me-not, assist with monitoring the equipment trolley, and assist in creating and engaging meaningful activities for the patients. As you can see here, there's some volunteers with me around the trolley. Not only did we connect with volunteers that would use the equipment, we connected with volunteers that had a skill. This particular lady was a beautiful harpist, and she came on board our program and did some wonderful work with the patients. This is just a picture of the forget-me-not. Same concept as the sunflower, originated from the sunflower. However, things were changed based on the units and, as I mentioned before. The importance of knowing a person's life story is very important when engaging with them in meaningful activity. An individual is motivated to engage in occupations that have personal significance to them, and knowing the importance of their lifestyle will connect us to that. Understanding what drives a person by using information that we have about them is also vital. Identify who they are to increase their self-esteem, their personhood, maintain their sense of self while they are in an environment that is unfamiliar, and reconnecting them back to roles in which they are familiar with, and using targeted interventions to reduce that functional decline. The program, as I mentioned before, Wendy is going to pass around just some things that are easily replicable, very cheap. There's some different laminated books. There's some other pictures of other equipment going around. But there's also some sensory pictures that if you open the laminate sheets, you'll actually smell the image that is on the sheet. So not only is it visually appearing, but it's enhancing the senses. If someone goes to eat it, or if they use it inappropriately, it can be discarded very, very quickly and redone again at a very cheap cost. So the a la carte based trolley is a diversional therapy based program that offers a wide selection of activities that are delivered from the trolley to the bedside. Staff and volunteers visit the patient that has been identified as needing it. They may have behavioural and psychological symptoms of dementia or a cognitive impairment, and they are offered a selection of recreation activities that are appropriate to them and their abilities and interests to meaningfully engage throughout the course of the day. Staff and volunteers can determine if patients need close supervision with an item or if they can be left with the item to do and staff return later to collect. Staff and volunteers can access the trolley. There's a primary storage area where a lot of the equipment is held. The bigger items like the cultural boxes, where you'll go and get specific things to put on the trolley, and then you can take them back to the primary storage and then reconnect later. So there's two areas, primary storage and the portable trolley that moves around. There's, as I mentioned before, the activity trolley has information sheets to assist staff and volunteers in their knowledge on activities, why we do activities and providing activities with people with BPSD. And depending on your clients that you have coming in through your hospital, the list of things that you can have in the trolley and infection control purposes, of course, is endless. So we had a lot of different cultural activities within our trolley, primarily Greek, Italian, different Asian cultures, and now we're filtering in a lot of the different activities from different Arabic cultures, because they're the cohort that comes through our sector. Each sector will be different, and it's about tailoring activities appropriate to the cohort of patients that you have. The research, it's been really positive, which is really good. We've had great feedback that the benefits extended beyond clinical staff and patients to allied health medical volunteers. Staff have said the timing of the project couldn't have been better. We've had a few come through the unit at the same time with particularly testing behaviours. The level of staff input and enthusiasm to try and determine the person's needs, best way to manage the situation was incredible. Staff turned what normally would have been very frustrating learning curve for the staff into an opportunity to be a patient advocate, implement person-centred activities and try new approaches. Volunteers have felt very connected with the program, so connected that they have said that if the program ended, they would still keep coming in because they feel like they're engaging meaningfully with the patient outside of just assisting them with a meal. So the evaluation has been very positive. With the positive, we have had some suggestions for improvement for the program. The main areas is that the sustainability of the program is limited if the hospital system does not commit the necessary funds and staff time allocations to promote and extend the project outside of the pilot period. Staffing issues means the ability to promote and champion learning can be lost unless there's a commitment to ongoing regular education. And there needs to be a commitment to embed recreational therapy expertise within each hospital system so that the continued training and updating of staff and volunteers on a regular basis can continue to occur. I will now pass you over to Wendy, who's going to go through a case study and how a patient would come into the unit and then go through the process. So I'll pass you over to her now and certainly take questions after if you have any questions. Hope they're taking up too much time.
Thank you. So you've heard the way, the why, and the research and the serious side. Well, this is what it really looks like for a person who may have a cognitive impairment or a dementia that is admitted to this acute hospital. So in this case study, Molly Smith, not a real name, is an 85-year-old woman with a diagnosis of Alzheimer's type dementia and associated BPSD. She was admitted to St Vincent's Hospital in Melbourne, Gen Unit, on the 30th of September last year after a fall where she suffered a Colles fracture of the left ulnar and radius that subsequently underwent open reduction and internal fixation. Now, Mrs Smith usually resides at home with her husband and daughter, who are her main carers. Basically, she's had a recent history of a urinary tract infection, which is well now, but that would probably indicate how she came about the fall. She experiences some poor new learning capacity and some disorientation to time and place, and she has a short attention span. Her difficulties, she experiences difficulties with behaviour regulation and insight, and some expressive and receptive language problems, but she can communicate using basic language and single-step instructions. So Mrs Smith presents with agitation and intrusive wandering. Mrs Smith was wandering around the ward and entering other patient rooms, and on one occasion she was found in an adjacent ward sleeping on a vacant bed. So we all know this, and I'm preaching to the converted here, but people with dementia are vastly underoccupied, and this is even more so in an acute hospital setting. But basically, I strongly believe, and I know Danielle does, that when people with dementia are given, they have abilities, and when they're given the appropriate environment and opportunities, that their potential can be realised. So occupation is a key to unlocking this potential, and obviously DB Mass is going to talk very much about non-pharmacological approaches. We agree that the dangers of pharmacological intervention are probably much higher and much less successful than a good non-pharmacological approach. So basically, we also acknowledge that there is a link between unmet needs and BPSD, and we all need to be stimulated and occupied. So people with dementia who are in an acute hospital, perhaps more so. So the a la carte trolley sort of features some good things that make enabling activity effective. So they're activities that are easily modified. So you saw that. When we handed around, now that cost us photocopying, you know, and a spray of the dementia perfume with a laminating pouch. Now that wouldn't have cost a great deal of money, I reckon.
You don't laminate the pouch because then you can't smell it.
Because then you can't smell it. That's why we put them in the laminating pouch, because it sticks. But that cost us virtually nothing. You know, probably the cost of the photocopying and a few squirts of the dementia spray, except it's called Demeter, but I just think it should be called Dementia. Basically, that costs nothing, and that is the most, you know, I saw the pleasure on this side of the room. People were killing themselves laughing. But then I saw someone else here got the horse book, and they started smelling it, hoping for a horsey smell. You know, so I think that's a really good thing. So a good activity, whether you have dementia or you don't have dementia, is something that's modifiable, something that's repetitive. So something with a single step that you can repeat over and over again and be successful at is a good activity. Something that's familiar and routine. You know, and this goes along with something that every single speaker has talked about, that idea of someone having something that is meaningful to them and that they can do in a routine way, because that sort of normalises our life. Multisensory focus is often very good. Preserving dignity is utmost important. Having fun is also good. And one of the things I find is, when I first started out many, many years ago in Queensland at Toowoomba Base Hospital, yes, that was my first job, even though I'm a Melbourne girl, I used to plan all my activities and plan all my interventions for the person. And then I really quickly realised that the person that I should be planning activities with were the nursing staff, because if they enjoyed it and they engaged in it, then the patients, which is what we used to call them then, would engage as well. So I know that sounds very strange and very controversial, but that's the truth. If you aim an activity that is fun and allows for opportunity, then people are going to be able to, you know, get involved and enjoy it. And then we look at the process rather than the outcome. So basically, the nurses then looked at Mrs. Smith and they said, well, you know, what maybe is the possible underlying message for her wandering? What is she trying to tell us something? Is she distressed? Is she uncomfortable? What's going on with her? They looked at her pain, they looked at any sensory loss or hearing aids or glasses that she may need, looked at her dentures, which is really important. They completed an organic screen, or some people call that a full ward test, or, you know, basically a delirium screen. They looked at the full medical review of her current medications in conjunction with the old age psychiatrists that we have on hand at DBMAS to rule out any sort of drug-induced akathisias. And also the nurses completed their own risk assessment. The nurses then contacted DBMAS Victoria to say, look, we just want to discuss this case a bit further and see if there's anything further you would recommend beyond our recommendations. Because, of course, all these nurses are trained because they've attended the program that we run. And in this case, because it was so complex and there was a few risk factors they were a bit nervous about with Mrs. Smith, they completed a concept map with Molly's family. Oops. So basically, we use a concept map designed and based on the Alzheimer's Australia principle of the caused problem-solving approach. Are you all familiar with that? Is that national or is it just a Victorian thing? Okay, so it's a really lovely sort of way of thinking of problem-solving difficulties with someone with dementia or any problems. So the C stands for communication, the A for activity, the U for unwell or unmet need, the S for story, the E for environment, and the D for dementia. So every single person thinking about Molly's care, including her family, would think about these issues. And this is sort of what a concept map looks like, and it's based on the work by Sue Aberdeen and others. But she wouldn't like it in boxes, I've got to tell you. But that's what it looks like, and this is what it really looks like when you type it up, but this is what it really looks like when you do it on a ward. Okay, so it's a lot messier than what we do. But as you can see, it's a crazy way, or probably a crazily clever way, of problem solving all the issues that could be confronting Molly at any one time. So it takes into account who she is, her life story, but it also takes into account her dementia and her experience of her disease process, her any wellness or unwell issues, any comorbidities like the urinary tract infection or pain coming from this recently fractured wrist, to her communication, to her environment, to who she is and what she likes. Now, it turns out that the care team did the right thing, you know, with their allied health colleagues, and they looked at, they knew that it was important to know who Molly was, what was going on before they would ever be able to manage this BPSD. And so they wanted to get that idea, and they wanted to prevent any functional decline that happens when someone with dementia, well actually anybody, goes to an acute hospital. You know, they experience significant functional decline. So they wanted to reduce that. So they completed her forget-me-not-many social profile with the daughter and the husband, and they assessed whether she was okay to have the volunteers work with her. So it turns out that as they know, she had the language problems as I spoke about. But really interestingly enough, Molly loves music, they found that out. She was an active woman who loved to walk, and she always prided herself on being really well groomed. And she loved to clean, and she kept a beautiful house. She was never apart from her husband from the night of her wedding and in all her 50 years of marriage. She'd never, ever in her life stayed in a hospital. So she had her daughter at home. So we're getting some clues here about what might be going on for Molly and how traumatic being in hospital would be for her. She has a great deal of difficulty finding her way and has been found all around the place. And basically we understand with regards to her dementia that wandering may be associated with the impairment of her frontal, parietal, temporal lobes and her limbic system. So we can actually get a feel of what might be going on in terms of her brain. Okay, so being an awesome bunch in this unit, they suddenly realised that they needed to get some things happening for Molly. So they developed an individual routine of activity, which they put on a board near her bed. They allowed her to have a volunteer input because she wasn't a risk, and you know, she needed that. They altered the environment so they to increase the cues for her, and that included a today is the day planner and signage and templates. Now the signage are as simple things as a photograph with bright contrast for the toilet. The other little simple thing that we did is get them to turn lights on and open blinds and curtains during the day so she knew where things were, and close the curtains and dim some lights in areas that she didn't need to go into at night. Really simple. And like we said, all these things we can do now and they don't cost us any more money. It's just behavioural stuff. The other really important thing is that Molly was a slim lady and they used a template for her lunch. So this was a red placemat, sorry Danielle, a red placemat that she would use when she was eating her lunch, so she was more engaged and knew where her food was because it was white cutlery and white sort of creamy food, if you know what I mean. If anyone's been to an acute hospital, I'll probably down south, not up here, of course. They also developed a sensory box for her, and this was in conjunction with her family. And this was a box that they had in her bed that had a whole lot of things that she was interested in and that she could explore at any one time with a carer, a volunteer or a nursing staff member. They introduced a sensor alarm for her bed and chair. The volunteer takes her for a walk twice a day, and they, as I said, improved the lighting. They rearranged her room to hide her daytime clothes at night so that she was not cued to go and get dressed. And they brought in photographs of her husband and daughter, so they were on display with a note on the back so that the staff could quickly read and go, Molly, tell me about this handsome gentleman. Oh, that's my husband. You're a lucky woman, etc. So you can imagine all the lovely conversations that would happen from that. Or isn't your daughter a beautiful woman? Doesn't she look like you? Or these are your grandchildren, etc. So that's really important. The night staff developed a routine with her because I don't know if you realise, but Danielle trained all the night staff as well. She went in at ungodly hours to run education sessions for the night staff, and they developed a relaxation and lemon balm hand massage routine with her every night, so that settled her down for the night. And the forget-me-not symbol was displayed on her journey board, and her profile was next to her bed. So any new staff could quickly open it, read the pertinent stuff, and know Molly's story as per the family wanting them to know the story. And cue cards were used. So even though we know Molly speaks English, cue cards were really handy with a big picture of what they wanted her to do, so that that's an extra cueing, a visual cueing for her to know, yep, okay, you're wanting me to go to the bathroom now, or you're wanting me to go to the toilet now, or we're going to go for a walk. Really just simplifying things and making it easier for her. So the sorts of activities on the trolley that Molly could partake of and did was music, clapping along to music in a room, walking, marching, dancing. So you can imagine the awesome dancing that went on in this room. Kicking a large plastic beach ball around. Now you might all go, what? You know, if you're doing it in a confined place, it's fine. And it is hysterically funny. You can hit, and a plastic beach ball, or even better, a balloon costs less than 10 cents. You have some in your pocket, you blow them up, and you whack it at them. And they whack it back, and you do that. And you make sure you burst it and then put it in the bin afterwards, so it's not a choking hazard for someone who, you know, puts things in their mouth. But this is a simple, quick activity that, no matter who you are, makes you laugh. You know, it is a good thing to do. Asking help. So they got her to help them with things. So they gave her a spray bottle and a cloth. The spray bottle had water in it, and they asked her would she mind just wiping down some tables and stuff, and thanked her very much after she performed those activities. Basically, we allowed her to continue her role as a person who prided herself on being a great housekeeper. Now, if she hated housekeeping, that wouldn't be a job we'd give her to do. But, you know, someone like me, yeah, I'd love that. I'd be washing down the walls or whatever. So basically there's sort of things. Having a broom handy, getting someone to sweep, gives someone a job to do, and making sure that you thank them afterwards. And reminiscence, of course, because we have a life story and we have these beautiful photographs. Obviously, here's a whole lot of wonderful other activities that we had on the list, and these are all things that obviously you can read later when you're looking at the overheads if you want to, but these are all things that can be easily done in an acute hospital. And one of the great things about these things is that they can last for 10 minutes in duration, they can be a quick intervention, they can be an intervention that a volunteer or a family member can do, or a person can be left to do on their own. They don't require a huge amount of hullabaloo, you know, to get it done. They're easy, they're user-friendly. And by user-friendly, I mean user-friendly for the nurse and staff, which is really, really important if you want something to stick. Okay, so this brings us to the end. What are we offering? So at the moment, Victoria is rolling out our acute hospital project, or actually the Forget-Me-Not project, as it's called now. And so we offer each hospital a 6-month program to help assist building the capacity of their staff. And we're planning to repeat this process through as many hospitals that sign on in Victoria. I think we're moving on to Barwon Health next. I hope I'm allowed to say that. Julie, if you're watching on the Skype thing, I hope I was allowed to say that. And anyway, that's my boss. And that's pretty much what we do. But our approach will be that, you know, it'll be different for each hospital we go to because they'll have a different set of things, but ultimately I think the underpinning things will be, the most important things will be flexibility and providing a good basis of understanding for managing BPSD in a respectful and non-pharmacological way, which is the DBMS way, isn't it? I see all our DBMS people nodding. Yeah. So thank you so much. Oh, and then here's another slide of some beautiful people.
With a red trolley this time.
See, it's red. This was the fast trolley, and the other one was the slower trolley, the blue one. So there's our email address, and you're very welcome to contact us if you want any information. Thank you. And whoever wants to email us, they're allowed to keep them on.
Yes, the 5 things will have to come back.
Yes. Thank you, Wendy and Danielle. We really appreciate that. We've got a small gift to show our appreciation, and also for Teresa, who was speaking before. I'm trying to think about planning a surgery now, and if I can't get into the PA, I'm going to head down to Victoria. So, great.
Hopefully,
Okay. Thank you, everyone, for your time today. And we did go a little bit over, but I'm sure you'll forgive us with that last presentation. I'd really like to thank sincerely all of our presentations and our talkers today, particularly Dr. Draper, who's heading around the country, and I think you're at Canberra, is it tonight and tomorrow? So thank you all for your participation. Just to help us improve on our future events, could you please fill out the feedback forms that were in your bags? You can leave them at the reception desk out the front. Also, if you did want to claim your C&E points, give them to one of the staff members there, and they'll provide you with your certificate for today. We've got a little bit of other housekeeping to do for you. If you do want copies of the PowerPoints, Some will be available. The full set might not be available. Just got to do some minor editing of them on our website. So if you go to our website and you look up this event, we'll have them on that page in the next couple of days. It won't happen, certainly won't happen today. Before we finish, I just wanted to let everyone know about a few events that are coming up. Our next lecture series, our next lecture in our lecture series will be in September during Dementia Awareness Month in Brisbane on Monday the 22nd of September. It's with Steve Milton, and he'll be our keynote speaker on dementia-friendly communities. And we'll be holding our second consumer forum for the year as part of this event. Christine Bryden's also going to be working with us during that time to find a dementia-friendly venue, because we think, particularly on that topic, we need to ensure that that venue is dementia-friendly as part of our broader dementia-friendly work. That event is also C&E points available for your attendance. Also, for those of you who are free next Friday night, we're holding our first, it's not our first, it's our, is it our first? Not sure. We're having canopies and cocktails with Ida Buttrose to launch our Bring It to the Table event. It's the first official launch we've done for Bring It to the Table. And you can book your tickets to join us there. There are flyers out the front. They're $85 a ticket, and all proceeds go to a good cause, Alzheimer's Australia. So I think that is it. Thank you to also the community relations team for all of their work today and making sure that we've been looked after and organising speakers on the food and the event. Done a wonderful job for us, so thank you. That's it. We've got afternoon tea outside. You can stick around and have a chat, and please travel safely. Did I get everything? Did I get everything?
Yeah, you were good. It was fun. Oh.